هنبدأ بمحاضرة لدكتور أندرو جامز. اللي بيشرفنا هو دكتور أندرو جامز، أمريكي بس بيشتغل في باريس في فرنسا. I think Dr. Andrew Gams is one of the pioneers of minimally invasive surgery, and he's interested in hepato-pancreatico-biliary surgery. We'll enjoy a lecture. He has a special interest in artificial intelligence, and as he told me, he is preparing for a PhD for artificial intelligence in surgery. I think this is the future of surgery, which is artificial intelligence. And it will be very nice to hear the basics for artificial intelligence, which is a field somehow new to all of us. الحقيقة اليوم إن شاء الله إحنا هنسمع محاضرة للدكتور أندرو جامز دلوقتي. بعد كده هننزل العمليات، نشتغل حالة left lateral hepatectomy، وفي حالة fundoplication إن شاء الله هنشتغلها at the same time. I hope you will enjoy the second day of our workshop. Thanks. Dr. Andrew Gams.
Thank you for that kind introduction. I'm going to keep my jacket on if it's okay. I'm a little bit colder here in Egypt than I thought I would be. It's wonderful to be here in Mansoura. As you can see, I actually, maybe it's written here, yeah. I work in Poissy, France, which actually is where King Louis IX was born. He became known as Saint Louis, and he's very important in France. I actually live on an island in the center of Paris called the island of Saint Louis. You maybe know of St. Louis in the United States, where I was born in St. Louis. I was born in New York, not in St. Louis. But King Louis IX was captured by the Egyptians in Mansoura, and as you know, I didn't know Mansoura means victory. So it's very interesting for me to be here, especially coming from Poissy, because I pass the church where he was baptized every day on my way to work. So enough about that. Currently, I'm going to talk about artificial intelligence and the promise of autonomous actions. We're actually editing 2 books for Springer Nature. They wanted 2 books from us. One is called Artificial Intelligence and the Promise of Autonomous Actions, which is what we'll be talking about today. But another book that they want that we're doing currently is called Computerized Visualization in Surgery. So this is a very hot topic, and hopefully at the end of my talk you'll understand a little bit more what it is and why it's important. So about a year ago I was asked to be the editor-in-chief of a new journal. They initially wanted to call it Intelligent Surgery, but then I suggested Artificial Intelligence Surgery, and that's why it's called that. We're going to talk a little bit about the journal and the website. We're going to talk about what the difference is between weak artificial intelligence and strong artificial intelligence. We're going to talk about the 6 levels of autonomy, because a lot of surgeons, when they hear artificial intelligence, they get very defensive right away, and they say, oh, I don't want a robot doing my surgery. I want the surgeon, and it's much more complex than that, and we'll talk about that in a bit. And then I'm also going to show some real-life examples of autonomous actions in surgery, in healthcare in general, and hopefully you'll realize that actually this has been around a lot longer than we realized. So here's the journal. It's called Artificial Intelligence Journal. The website is aisjournal.net. It was launched in February of last year. It's published quarterly, and the first issue actually came out in December. So you can go online and you can see the first issue. The second issue is coming out in March. This is just what the website looks like. This is an editorial that I published that is going to talk about a lot of the things I talked about today. It's an open access journal, so you can go and download this editorial at your leisure. So in that journal article, I'll show this image in the journal article. This is known as the Geithner hype cycle, and this is used mainly in business to talk about the excitement for a new product or for a new concept. All right, so when you look here, let me see if I have a pointer. Is this a pointer? Anybody have a pointer? I don't know if I can get the, yep, how's this? You can, actually it's fine, I have this working now. So I think the dawn of artificial intelligence actually started back with minimally invasive surgery, because it was really the first time that we put a computer between the surgeon and the patient. with minimally invasive surgery, with cameras, you know, there are microprocessors. We're able to do things that we weren't able to do with open surgery as easily. Okay, and then, as we know, robotic surgery. Oh, thank you so much. Right here. Yes, great. Then, as you can see, robotic surgery came along. Even more minimally invasive surgery came on at like notes. And we had really a peak of inflated expectations. Everybody was like, the robot, I want to use the robot. This is amazing. And then we realized that to actually have autonomy or for the robot to actually do anything for us was much harder. And over the last decade or so, the computer scientists have developed things like machine learning, which is really algorithms, mathematical models used so that the machine or the computer can actually develop things or figure out things that it wasn't necessarily programmed to do so. Okay, so this is really the dawn of artificial intelligence, of useful artificial intelligence as we know it. Deep learning is a form of machine learning where they actually model the algorithms on the anatomy of the human brain. You have different layers of algorithms that are all interconnected, like neurons interconnected, and the computer is able to figure out things, again, that it wasn't necessarily designed to do so. And deep learning does this more so than machine learning. Machine learning, it's actually more structured, and it's really more, you know, we're not going to get into the algorithms, but it's really a form of what's called supervised learning. The human who does the algorithms really guides what the machine is doing. But deep learning is unsupervised learning, and here is really where you begin to have the computer figuring out things that it wasn't necessarily programmed to do so. Natural language processing, everybody who uses Google Translate, or whenever you dictate into your computer for maybe your notes are dictated automatically, that's from natural language processing. The ability of the computer to understand what we're saying, subtleties of language, is what natural language processing is about. And then computer vision. This is the ability of the computer to see. Okay, and it can see in many different ways. It can see similar to the human eye using pixels or what have you. But again, computer vision is possible because of deep learning. All right? And this deep learning revolution really occurred, again, about 10 years ago. Okay? So we realized we were a little bit in a trough of disillusionment. We realized how hard autonomous actions in surgery were actually going to get. And I think when the journal was launched, we're really down here as far as what we thought artificial intelligence could do. But hopefully at the end of my talk, you realize that we actually have more autonomous actions in healthcare than we thought, okay? And then this, just to finish, the Gartner hype cycle is the slope of enlightenment, and then ultimately the plateau of productivity where the real work begins. And we're not quite there yet, but we're closer than you think. So artificial intelligence surgery is different from artificial intelligence in healthcare because surgery is a dynamic art. It involves movement. Unlike artificial intelligence with radiomics, when you look at CT scans and you diagnose things, you have the computer diagnose it for you, or you help the computer tell you what is the best treatment algorithm for a patient. That involves really decision making, but there's no movement involved. But that's why artificial intelligence surgery, or surgery in general, is different from all of the other healthcare fields. Surgery, interventional radiology, and gastroenterology, these are arts that involve movement. You know, that's why if you notice in many centers around the world, they're fusing the HPB departments. They have endoscopy, interventional radiology, and surgery all in the same department. You have people who are doing surgery, ERCPs, and percutaneous ablations, portal vein embolizations, and these are liver surgeons that do all three. Does that exist at all in Egypt? Yeah. So that's really the future, and that happens in France, but it doesn't happen very often in America. But it's really important to have all these disciplines fusing because that's the way things are going, and to fight it is a waste of time. No. But in some centers, the surgeon does all three. That's my question. Yeah, yeah. Okay, but that's great that you do ERCP. That already is a lot. But in places in France, some places in France, they have the surgeons doing all three. Or, more importantly, the surgery department, they have surgeons who do one, surgeons who do another, and surgeons who do another. But the surgeons do all three, which is, I think it's important. Surgeons have always been fighting against minimally invasive. We lost endoscopy. The surgeons did colonoscopy and ERCP before the gastroenterologists, and we lost that field. In cardiac surgery, it was the surgeons who developed cardiac stenting and angiography, but the surgeons were too good to do it, so they didn't do it, and then the cardiology developed. So it's important that we stop giving up these new techniques that we're developing, which is one of the reasons why I think it's important for us as a group to be very intimately involved with artificial intelligence, because if not, we're going to find ourselves, I don't want to say without a job, but we're going to find ourselves losing even more things. So, current robotics, however, is just telemanipulation. Current robotics is very different from, current robotics is not very different from laparoscopy. We're just working in a laparoscopic field, and we have a surgeon at a console, but it's just laparoscopy, It's really, there's no autonomy, okay? Because a human is still controlling all of the actions 100%. So it's not really strong artificial intelligence. Again, as I said, artificial intelligence implies autonomous action. So we're going to talk a little bit more about that. Weak AI and strong AI. Weak artificial intelligence is any automatic actions. That's like an automatic stapler device with Ethicon or the handheld staplers. That's an example of an automatic action. I don't know if you've used the Echelon. You hit a button, it fires a stapler, and that's it. But strong AI implies independent actions, and that's where people are most interested in AI. But the reality is that we do have examples of weak AI, okay, already. So what are the 6 levels of autonomy? Level 0 designates no autonomy. Level 1 is defined as telemanipulation of a robot. So right now the Da Vinci is only level 1 autonomy. Level 2 corresponds to a limited autonomous action. So an example of this would be a stapler by Medtronic, like the Tri-Stapler, that is a powered stapler that has a sensor. When the tissue is too thick, it won't fire. When the tissue is not thin enough, it won't fire. There are algorithms inside the device that are making decisions, and that's a perfect example of level 2 or limited autonomous action, okay? Level 3 is defined as conditional autonomy, where the surgeon selects among several autonomous actions that the robot can perform. We'll talk a little bit about this, but believe it or not, I would argue that the harmonic scalpel, which has 3 different settings, or the ligature, depending on how large the vessel is, it'll make a decision on how long it takes to cut a structure, how long it takes to seal a device. So that's actually an example of level 3. Level 4 include automated medical decision under a doctor's control. So they actually have, the cardiologists have an ablation device. They put a device inside the patient's arteries, into the heart, and it'll go into the atrium, and it'll autonomously detect areas of anomalies, and it'll autonomously do ablations. All right, it's a little robot that goes in the heart that will do all of these. It needs a human to put the device in the heart, but it will do it all by itself. The cardiologist is just waiting there until the procedure's over. And level 5, full autonomy, where no human control is necessary. I would argue that an AICD is an example of level 5 autonomy. An AICD is a defibrillator. It'll detect an anomaly in a patient's heart, and it'll shock them independently based on what it sees, and it'll save a human's life. So level 5 autonomy, in my opinion, in healthcare already exists. It doesn't exist in surgery, but exists in healthcare, and AICDs, defibrillators, have been around for a long time, as we all know. So what about the 4 classes of medical devices based on risk? Okay, so this is interesting. Level 1 devices have minimal risk for the patient and remain in limited contact with patients, and these include surgical instruments. So surgical instruments are considered class 1. Class 2 devices include things like CT scanners, ultrasound probes, and contact lenses. In a way, they have a higher risk than a surgical instrument according to this classification. Class 3 includes hemodialysis and implants like surgical meshes. And Class 4 includes implantable defibrillators and pacemakers. So they understand that this is the highest class of risk, but I wonder if a fifth class should be designated for devices that make real-time clinical decisions using artificial intelligence during procedures. So this is an article that we published about 6 months ago in Sensors. They contacted us and they were excited about our work in our journal, and they wanted us to write a review article on how we get to autonomous actions in surgery. This article, we don't have time to talk about it today. We'll talk about all the different algorithms that are being used to obtain artificial intelligence in surgery. Machine learning algorithms, neural networks, convoluted neural networks, artificial neural networks, all of it is discussed in here if you want. It's an open access journal, so feel free to go there. This just quickly has a list of some of the types of algorithms that I'm studying right now for my PhD in artificial intelligence. I'm studying supervised learning, again, this is all a form of machine learning. Supervised learning has things like support vector machines, random forest, and dynamic time warping. Then you have deep learning, which is a part of machine learning. Here you have unsupervised learning, and you can get your computer vision. And again, you have the neural networks that we talked about. And then the last one, which again is a form of machine learning, is reinforcement learning. This is the most important for autonomous actions because these Markov decision processes and these hidden Markov models and deep Q reinforcement learning are how the robot is learning from trial and error. All right? They have devised algorithms for the robot to learn from trial and error. They have already been around and they're already working on it. And they already have some very nice prototypes, which we'll talk about a little bit later. Things like automatic suture tying. They have robots that do gastrointestinal anastomoses, and they've shown that they can do it better than a human. So it's pretty amazing work. They also have robots that can autonomously aspirate blood during surgery. It can detect blood faster than humans. It can see blood off on the side of the screen that a human doesn't. It can alert the human, and it can automatically aspirate the blood. So I think all surgeons already use artificial intelligence. So as I talked a little bit before, we have things like monopolar and bipolar, and tissue sensing technology, which has actually been around since the 60s. This device, if you use it, you probably have, it analyzes 434,000 data points per second. Okay, so that's a lot of number crunching that a human can't do that this machine has been doing since the 60s. What about the ligature? They use an advanced vessel sealing algorithm. Like I told you, the device decides when the cutting is finished. The device decides when the vessel is sealed. You have different settings that you can choose from that give you a little bit of control, but this is an example of artificial intelligence surgery, and it's been around since my entire career. So what about this? The cyberknife. Do they have this in Egypt? The cyberknife? Okay. So this has been around since 1994. This was developed by a neurosurgeon, I believe. I'm not sure what country actually, so I won't even say. But again, this has been around for over 25 years. This is a robot that'll deliver external beam radiation in a way that's faster and more precise than a human can. When you do external beam radiation for a human, you have to set up the patient every time, give them treatments 5 days a week, 5 days a week for 5 weeks. When you use the cyberknife, you can give them 3 treatments and their treatment is done, okay? And this robot is very nice because it has an autonomous function. It'll move autonomously with movements of the heart and lung. You'll see in a moment these white stripes on the patient. It has these white stripes, and the robot, the computer, can tell when the patient is breathing. Here they are. And it'll move with movements of the chest wall and the heart, and it'll automatically move and give treatment exactly where it needs to be given. So this is an example of a very high-level example of a robot that has been around for 25 years that can give very precise external beam radiation better than a human. And it's no coincidence they call it the cyberknife, because this device has taken away a lot of surgery away from surgeons and is being done by a radiation oncologist. So we'll see it just in a moment. Here you can see it in action. You can see the tumor moving. Again, you have to set it up with imaging. The computer has to be programmed to tell where the radiation is supposed to be delivered to. That is still being done by a human, but it's being facilitated or improved on with artificial intelligence. But still, a human is controlling all of this, thankfully. And this is the part I want to show you. Because not only is it moving with movements of the chest wall, it also has a collimator which is moving autonomously to give the exact treatment dose to save as much additional tissue as possible. So again, you can imagine a human cannot do all of these changes autonomously as quickly as this robotic device. Okay? So that's that. So we talked a little bit about this, but I just want to show it again. I don't know if they have this device. This is the powered stapler from Medtronic. It's the, do we have this here today, or do we have the regular stapler? The regular stapler, okay. So this powered stapler has been around for about 10 years. It's changed company names many times. It's now called Signia. I can't even remember the other names. But this is a powered stapler that, as opposed to the Ethicon stapler, or the stapler we're using today, it has a sensor in it. And it'll tell whether the tissue is too thick or too thin. So this is an example of handheld robotics, also known as a collaborative robot or a co-robot, okay? So this is a little bit of, I think, the future for us that we need to be aware of. We need to be actively pursuing handheld robotics where the surgeon is kept in the loop, where the surgeon is at the bedside, and we'll show a little bit of video of how that can look like in the operating room. I'm not sure the safest way to more surgery is with the Da Vinci or a complete surgical system. I think maybe having robots at the bedside and the surgeon at the bedside might be the best way and the safest way to develop more of these autonomous actions. But as you can see, this gives a better staple firing, probably decreased leaks, decreased misfirings, better results, better for our patients. And this is just in a handheld device, which you can do in laparoscopy. And I'm not sure, I think they have this in the Da Vinci robot, but I'm not sure if it has sensing technology in it. I don't know if it'll stop if it's too thick or too thin. I don't know, maybe not. So here's an example of a laparoscopic device, handheld, that might have more intelligence than the robot. Okay, so this is important. And this is wonderful technology, and it shouldn't be ignored. And again, it's been around for 10 years. Here it tells you the different thicknesses, what have you, if it's dangerous, and it gives you intelligent information, and it'll make a decision on its own. Okay. So what about the Da Vinci robot? Sorry about that. As we talked about the Da Vinci robot, it is not an example really of autonomy in surgery, but there is one thing that it does that is autonomous and does make surgery better, faster, and safer, and that's the table. The table is made by Trumpf, and it is actually what's the word I'm looking for? It is in connection with the Da Vinci. So when you move the angle of the table, the robotic arms move autonomously with it. Before this integration existed, every time you wanted to change the angle of the bed, you had to take off the robotic arms, change the table, and then put it back in every time. So a lot of surgeons ended up just dealing with surgery with bad angles, not the right angle, because they became frustrated and they didn't want to take the time. But this is a wonderful example of autonomy in the operating room that exists today that is giving surgeons better visualization and possibly better results, okay? But again, it's not what you would think. It's not the robot itself. It's actually the table. All right, so this is another example of a handheld robot. This is used by the interventional radiologist, but I plan to use it when I do my liver ablations. This is a little handheld robot. It came out on the market this summer. It'll autonomously line up the needle to the patient so that all you have to do is push it in to a liver tumor, push it in for an endovascular leak. If you want to do a biopsy, it'll autonomously find where the tumor is, and all you have to do is push the needle in the depth that you want. So this is a beautiful example of a handheld robot. It's at the bedside. The interventional radiologist or the surgeon or what have you is still in the loop. They're the ones controlling the needle. They're the ones pushing the needle in. And think of the possibilities. Think of how many ablations you could do if you had this device. Instead of having to sit there with the ultrasound and constantly looking laparoscopically for the lesion, if you had this device, you could maybe start to treat people with more liver tumors. Maybe you could do it better. Maybe you could have decreased killing of healthy tissue. So again, this is a device that came out over the summer. It's available, and it could be a game changer, in my opinion. We don't need a $2 million robot. You can just have this for, I think, $80,000, and you already have robotics, and you can already have better outcomes for your patients and treat more tumors. So what about this? I don't know if I guess the Marvel movies probably made it here into Egypt, but Jarvis. This is actually something you can download on your iPhone now. It's an acronym for Marvel Comics. It was coined by Tony Stark, who became Iron Man. But Jarvis was named after Stark's family, loyal household butler, okay? And he became artificial intelligence that eventually became Vision. So that's why they call it that. You can download this on your iPhone right now for the low, low price of $49.99, okay? And you can have computer vision on your phone. This is a computer vision program that you can have that will show you whether you've obtained the critical view or not. You have someone, while you're doing a laparoscopic cholecystectomy or a robotic cholecystectomy, they hold up their iPhone on video mode, and when all of these criteria change from red to green, you know you've obtained the critical view of safety. And it's safe to put on the clips, it's safe to cut the ducts, and it's safe to cut the artery. Now, in America, you can imagine if you cut the bile duct and the lawyer finds out that you didn't use this device, in America, you can imagine that that family would become very wealthy. So I'm not saying that you need this to do a laparoscopic cholecystectomy, but I am saying that this might become the standard of care. And if you don't use it and you have a complication, you might be in trouble. All right? So again, you can download it on your iPhone. It exists today. It's very simple to use. And I think it's a great device for young surgeons. If it's the middle of the night and they're not sure what they're seeing, they can try this device. And it'll tell them, like, look, you need to call your senior. Maybe it'll save some phone calls. Who knows?
What's the name of this app?
Jarvis. Jarvis, J-A-R-V-I-S. Again, it's the name of Tony Stark, Iron Man's butler, before he became a robot, an artificially intelligent robot called Vision. Okay, so here's the artificial intelligence surgery hype cycle, a little bit more advanced now. You can see, I think, actually the dawn of minimally invasive was with endoscopy, then interventional radiology, then minimally invasive surgery, then maybe single incision, robotic, notes, what have you. Then we started to learn a little bit about simulation and training in like the late 90s. Machine learning came, all these things came. But then let's just talk a little bit more specifically about some of the issues that the computer has to overcome and has overcome. The computer can now identify different organs. It can identify different blood vessels. It can identify the portal vein from the common bile duct. You have augmented reality where images will get shown onto where you're operating. So again, you can see anomalies better. This already exists. And it actually already exists. You can buy this now in Europe. You have augmented reality for things like liver tumors and gynecology. Robotic single incision, not too impressed with that. But anyway, I wrote it here anyway. Virtual reality we have. Autonomous actions, as you can see, we have organ segmentation where you can separate things like the bile duct from the liver. You have that. Virtual navigation exists. You have colonoscopies now. You do a colonoscopy, and it'll tell whether you have a suspicious polyp, even if you don't see it. So that already exists. Okay, so that's already used in many hospitals. It's incredible. So autonomous interventional radiology, I showed you a little bit about what that might look like. We have that robot that already has some autonomy. And then again, we're getting a little higher up on the curve. So This just shows the publications on robotic surgery and artificial intelligence. Peaked around 10 years ago, and then following, the peak of inflated expectations and the trough of disillusionment, people have started to understand that artificial intelligence is very powerful. So I did this back in the middle of the year. So this is probably up to here. So as you can see, an interest in artificial intelligence and robotic surgery is skyrocketing, okay? And it's really been over the last couple of years. So this just gives you another more advanced hype cycle, just to show you that they've already done autonomous suture and knot tying. They already are working on autonomous dissection. They want you to upload your videos onto the internet, and they're actually going to use that as a library for robots to understand how to do dissection, right? So they've been calling you. You can do it right now. You can send them your videos, and it'll help the robot become more and more intelligent. So this already exists, and it's been around for several years. You have the robot can have situation awareness. It can tell if there's bleeding, if there's a problem. It can already do that. Phase recognition. It can tell what part of the operation you're at. So as you can see, and we already have some simple autonomous procedures. They have a robot who can do a gastrointestinal anastomosis. So as you can see, we're getting very, very further up along the curve. So these are just a list of the examples of autonomous actions that already exist in healthcare that we talked about. This is a list of commercially available devices with artificial intelligence, like vessel sealing, stapled anastomotic lines, automatic needle placement. You also have motion scaling and tremor reduction. The ophthalmologists use this. The neurosurgeons use this whenever they do microsurgery. You have organ segmentation, where the computer can already help you identify different structures and organs. As far as the prototype phase, you have autonomous laparoscope tracking, where the laparoscope will move, tell you where you should be looking during an operation. You have autonomous suturing and anastomoses, autonomous knot tying, you have situation, and then as far as theoretical phase is where you have situation awareness, phase recognition, autonomous pneumoperitoneal access. I'm working on a way to do this intelligently by listening, by using audio, believe it or not, for the computer to tell the different layers I'm going through. And again, as I mentioned, autonomous dissection, they're already working on it. It's in the theoretical phase, but they're working on it. So this is an article I just published in that first journal of artificial intelligence surgery, and it talks about what I've alluded to earlier, how we keep surgeons in the loop. And it is an article that's looking at people who do laparoscopic liver surgery for colorectal liver mets, either with a complete surgical system or with handheld robotics. And when I mean handheld robotics, I'm just talking about that intelligent stapler and a handheld robot to hold the laparoscope, because that's the way I like to do my surgery. I just compared it in a multicentric trial, and I showed that there are actually some advantages to doing it with handheld robotics. So I'm not saying it's better, but I'm saying we shouldn't forget about it. Especially as surgeons, we're pushing maybe, I don't want to say our demise, but we're helping them make us irrelevant, and we're walking blindly in that direction without reflecting, without even really understanding artificial intelligence. And that's the whole purpose of the books we're writing and the purpose of the journal. So what I think is we need collaborative robots, or cobots. And this is a company in France called Moon Surgical. It's actually developed by Brice Gaillet, which I know you all know. And so here you have a robot holding the camera, you have a robot retracting for him, and then you have the surgeon operating with two instruments so he can maintain haptics, he can still feel, he can have the benefits of robotics, right? And eventually this will move autonomously. It'll tell him where he needs to operate. But again, he has haptics. So why are surgeons ignoring this paradigm? Why are we digging our own grave? I don't know. So I think it's very important that we learn about handheld robotics, and that we just know what we're doing when we buy a Da Vinci. Okay? I think the Da Vinci is a great device for prostate surgery, for surgery in the pelvis, where a surgeon can't fit between the legs. So it has its place, but I think it's a bit of a shame that we're completely ignoring this paradigm. We're doing it at our own peril. Okay. So thank you very much, and I'll take any questions. Maybe that's enough.
Thank you, Dr. Andrew. It is amazing and stunning. I'm asking, is there a place for surgeons in the near future? I think we will be jobless.
Exactly. No, exactly. And that's why, I'm 49. I'm doing a master's in artificial intelligence now. I'm starting a PhD in artificial intelligence in July. Do you really think I need to do a PhD at this age? I'm getting tired myself, but I find it fascinating. I find it interesting, and I find it a shame that more surgeons of our generation are. And I'm glad you're interested and that you invited me to talk. That's a wonderful. That's a wonderful thing that you did. But I really feel like it's crucial that we don't ignore this, because otherwise we will become irrelevant. Maybe not in my lifetime, maybe not in your lifetime, but maybe in some of your younger guys' lifetime.
Yes, yes.
So.
Thank you, Dr. Andrew. Thank you very much. And we'll enjoy the operative dissection and steps you will perform for our case of left lateral segmentectomy. Thank you very much.
Great.
Thanks, Dr. Andrew.
Thank you.
شكرا يا جماعة. هنبدأ نجهز تحت في العمليات إن شاء الله، وربع ساعة وننقل بإذن الله.
Just to drag it out instead of talking
Can I take this lecture?
Yeah, it's there.
Give him my book.
Yes, I have it. Thank you so much. Can you sign it for me?
Yes, I write.
You did?
Sorry.
والرعايات. والنهاردة احنا لسه بنجدد التزامنا تجاه منظومة الصحة بتقديم أحدث النظم التشخيصية والعلاجية والدعم المستمر لكل شركائنا. صحة كل مريض هي محور اهتمامنا. دي الرسالة اللي بنؤمن بيها في غاليونجي من سنة 1979. الرسالة اللي خلتنا نبني شراكة مع كل العاملين في المجال الطبي ونتحالف مع أكبر الشركات العالمية عشان نواكب التطور اللي بيحصل في العالم ونقدم أفضل دعم للدكاترة وأفضل منتجات للرعاية الصحية. ولأننا في غاليونجي بنؤمن إن الرعاية الصحية من أهم عناصر التنمية المستدامة، كان لازم نعمل كل اللي نقدر عليه عشان نطور من نفسنا ونساهم في تطوير كل شركائنا في المجال الطبي في كل مكان في مصر. ندربهم ونساعدهم ونوفر لهم خدمات ما بعد البيع بصفة دائمة. من 40 سنة وغاليونجي بتبذل كل جهودها عشان تدعم منظومة الرعاية الصحية بكل إمكانياتها وبمجهودات شركائها من العاملين في الشركة. وبفضل الله قدرنا نساعد المرضى ووفرنا المعدات اللي تساعد في تشخيص حالتهم، تتابع علاجهم، وتساعد الأطباء في العمليات الجراحية والرعايات. والنهاردة احنا لسه بنجدد التزامنا تجاه منظومة الصحة بتقديم أحدث النظم التشخيصية والعلاجية والدعم المستمر لكل شركائنا. صحة كل مريض هي محور اهتمامنا. دي الرسالة اللي بنؤمن بيها في غاليونجي من سنة 1979. الرسالة اللي خلتنا نبني شراكة مع كل العاملين في المجال الطبي ونتحالف مع أكبر الشركات العالمية عشان نواكب التطور اللي بيحصل في العالم ونقدم أفضل دعم للدكاترة وأفضل منتجات للرعاية الصحية. ولأننا في غاليونجي بنؤمن إن الرعاية الصحية من أهم عناصر التنمية المستدامة، كان لازم نعمل كل اللي نقدر عليه عشان نطور من نفسنا ونساهم في تطوير كل شركائنا في المجال الطبي في كل مكان في مصر. ندربهم ونساعدهم ونوفر لهم خدمات ما بعد البيع بصفة دائمة. من 40 سنة وغاليونجي بتبذل كل جهودها عشان تدعم منظومة الرعاية الصحية بكل إمكانياتها وبمجهودات شركائها من العاملين في الشركة. وبفضل الله قدرنا نساعد المرضى ووفرنا المعدات اللي تساعد في تشخيص حالتهم، تتابع علاجهم، وتساعد الأطباء في العمليات الجراحية والرعايات. والنهاردة احنا لسه بنجدد التزامنا تجاه منظومة الصحة بتقديم أحدث النظم التشخيصية والعلاجية والدعم المستمر لكل شركائنا. صحة كل مريض هي محور اهتمامنا. دي الرسالة اللي بنؤمن بيها في غاليونجي من سنة 1979. الرسالة اللي خلتنا نبني شراكة مع كل العاملين في المجال الطبي ونتحالف مع أكبر الشركات العالمية عشان نواكب التطور اللي بيحصل في العالم ونقدم أفضل دعم للدكاترة وأفضل منتجات للرعاية الصحية. ولأننا في غاليونجي بنؤمن إن الرعاية الصحية من أهم عناصر التنمية المستدامة، كان لازم نعمل كل اللي نقدر عليه عشان نطور من نفسنا ونساهم في تطوير كل شركائنا في المجال الطبي في كل مكان في مصر. ندربهم ونساعدهم ونوفر لهم خدمات ما بعد البيع بصفة دائمة. من 40 سنة وغاليونجي بتبذل كل جهودها عشان تدعم منظومة الرعاية الصحية بكل إمكانياتها وبمجهودات شركائها من العاملين في الشركة. وبفضل الله قدرنا نساعد المرضى ووفرنا المعدات اللي تساعد في تشخيص حالتهم، تتابع علاجهم، وتساعد الأطباء في العمليات الجراحية والرعايات. والنهاردة إحنا لسه بنجدد التزامنا تجاه منظومة الصحة بتقديم أحدث النظم التشخيصية والعلاجية والدعم المستمر لكل شركائنا. صحة كل مريض هي محور اهتمامنا. دي الرسالة اللي بنؤمن بيها في غاليونجي من سنة 1979. الرسالة اللي خلتنا نبني شراكة مع كل العاملين في المجال الطبي ونتحالف مع أكبر الشركات العالمية عشان نواكب التطور اللي بيحصل في العالم ونقدم أفضل دعم للدكاترة وأفضل منتجات للرعاية الصحية. ولأننا في غاليونجي بنؤمن إن الرعاية الصحية من أهم عناصر التنمية المستدامة، كان لازم نعمل كل اللي نقدر عليه عشان نطور من نفسنا ونساهم في تطوير كل شركائنا في المجال الطبي في كل مكان في مصر. ندربهم ونساعدهم ونوفر لهم خدمات ما بعد البيع بصفة دائمة. من 40 سنة وغاليونجي بتبذل كل جهودها عشان تدعم منظومة الرعاية الصحية بكل إمكانياتها وبمجهودات شركائها من العاملين في الشركة. وبفضل الله قدرنا نساعد المرضى ووفرنا المعدات اللي تساعد في تشخيص حالتهم، تتابع علاجهم، وتساعد الأطباء في العمليات الجراحية والرعايات. والنهاردة إحنا لسه بنجدد التزامنا تجاه منظومة الصحة بتقديم أحدث النظم التشخيصية والعلاجية والدعم المستمر لكل شركائنا. صحة كل مريض هي محور اهتمامنا. دي الرسالة اللي بنؤمن بيها في غاليونجي من سنة 1979. الرسالة اللي خلتنا نبني شراكة مع كل العاملين في المجال الطبي ونتحالف مع أكبر الشركات العالمية عشان نواكب التطور اللي بيحصل في العالم ونقدم أفضل دعم للدكاترة وأفضل منتجات للرعاية الصحية. ولأننا في غاليونجي بنؤمن إن الرعاية الصحية من أهم عناصر التنمية المستدامة، كان لازم نعمل كل اللي نقدر عليه عشان نطور من نفسنا ونساهم في تطوير كل شركائنا في المجال الطبي في كل مكان في مصر. ندربهم ونساعدهم ونوفر لهم خدمات ما بعد البيع بصفة دائمة. من 40 سنة وغاليونجي بتبذل كل جهودها عشان تدعم منظومة الرعاية الصحية بكل إمكانياتها وبمجهودات شركائها من العاملين في الشركة. وبفضل الله قدرنا نساعد المرضى ووفرنا المعدات اللي تساعد في تشخيص حالتهم، تتابع علاجهم، وتساعد الأطباء في العمليات الجراحية والرعايات. والنهاردة إحنا لسه بنجدد التزامنا تجاه منظومة الصحة بتقديم أحدث النظم التشخيصية والعلاجية والدعم المستمر لكل شركائنا. صحة كل مريض هي محور اهتمامنا. دي الرسالة اللي بنؤمن بيها في غاليونجي من سنة 1979. الرسالة اللي خلتنا نبني شراكة مع كل العاملين في المجال الطبي ونتحالف مع أكبر الشركات العالمية عشان نواكب التطور اللي بيحصل في العالم ونقدم أفضل دعم للدكاترة وأفضل منتجات للرعاية الصحية. ولأننا في غاليونجي بنؤمن إن الرعاية الصحية من أهم عناصر التنمية المستدامة، كان لازم نعمل كل اللي نقدر عليه عشان نطور من نفسنا ونساهم في تطوير كل شركائنا في المجال الطبي في كل مكان في مصر. ندربهم ونساعدهم ونوفر لهم خدمات ما بعد البيع بصفة دائمة. من 40 سنة وغاليونجي بتبذل كل جهودها عشان تدعم منظومة الرعاية الصحية بكل إمكانياتها وبمجهودات شركائها من العاملين في الشركة. وبفضل الله قدرنا نساعد المرضى ووفرنا المعدات اللي تساعد في تشخيص حالتهم، تتابع علاجهم، وتساعد الأطباء في العمليات الجراحية والرعايات. والنهاردة احنا لسه بنجدد التزامنا تجاه منظومة الصحة بتقديم أحدث النظم التشخيصية والعلاجية والدعم المستمر لكل شركائنا. صحة كل مريض هي محور اهتمامنا. دي الرسالة اللي بنؤمن بيها في غاليونجي من سنة 1979، الرسالة اللي خلتنا نبني شراكة مع كل العاملين في المجال الطبي ونتحالف مع أكبر الشركات العالمية عشان نواكب التطور اللي بيحصل في العالم ونقدم أفضل دعم للدكاترة وأفضل منتجات للرعاية الصحية. ولأننا في غاليونجي بنؤمن إن الرعاية الصحية من أهم عناصر التنمية المستدامة، كان لازم نعمل كل اللي نقدر عليه عشان نطور من نفسنا ونساهم في تطوير كل شركائنا في المجال الطبي في كل مكان في مصر، ندربهم ونساعدهم ونوفر لهم خدمات ما بعد البيع بصفة دائمة. من 40 سنة وغاليونجي بتبذل كل جهودها عشان تدعم منظومة الرعاية الصحية بكل إمكانياتها وبمجهودات شركائها من العاملين في الشركة. وبفضل الله قدرنا نساعد المرضى ووفرنا المعدات اللي تساعد في تشخيص حالتهم، تتابع علاجهم، وتساعد الأطباء في العمليات الجراحية والرعايات. والنهاردة احنا لسه بنجدد التزامنا تجاه منظومة الصحة بتقديم أحدث النظم التشخيصية والعلاجية والدعم المستمر لكل شركائنا. صحة كل مريض هي محور اهتمامنا. دي الرسالة اللي بنؤمن بيها في غاليونجي من سنة 1979، الرسالة اللي خلتنا نبني شراكة مع كل العاملين في المجال الطبي ونتحالف مع أكبر الشركات العالمية عشان نواكب التطور اللي بيحصل في العالم ونقدم أفضل دعم للدكاترة وأفضل منتجات للرعاية الصحية. ولأننا في غاليونجي بنؤمن إن الرعاية الصحية من أهم عناصر التنمية المستدامة، كان لازم نعمل كل اللي نقدر عليه عشان نطور من نفسنا ونساهم في تطوير كل شركائنا في المجال الطبي في كل مكان في مصر، ندربهم ونساعدهم ونوفر لهم خدمات ما بعد البيع بصفة دائمة. من 40 سنة وغاليونجي بتبذل كل جهودها عشان تدعم منظومة الرعاية الصحية بكل إمكانياتها وبمجهودات شركائها من العاملين في الشركة. وبفضل الله قدرنا نساعد المرضى ووفرنا المعدات اللي تساعد في تشخيص حالتهم، تتابع علاجهم، وتساعد الأطباء في العمليات الجراحية والرعايات. والنهاردة احنا لسه بنجدد التزامنا تجاه منظومة الصحة بتقديم أحدث النظم التشخيصية والعلاجية والدعم المستمر لكل شركائنا. صحة كل مريض هي محور اهتمامنا. دي الرسالة اللي بنؤمن بيها في غاليونجي من سنة 1979، الرسالة اللي خلتنا نبني شراكة مع كل العاملين في المجال الطبي ونتحالف مع أكبر الشركات العالمية عشان نواكب التطور اللي بيحصل في العالم ونقدم أفضل دعم للدكاترة وأفضل منتجات للرعاية الصحية. ولأننا في غاليونجي بنؤمن إن الرعاية الصحية من أهم عناصر التنمية المستدامة، كان لازم نعمل كل اللي نقدر عليه عشان نطور من نفسنا ونساهم في تطوير كل شركائنا في المجال الطبي في كل مكان في مصر، ندربهم ونساعدهم ونوفر لهم خدمات ما بعد البيع بصفة دائمة. من 40 سنة وغاليونجي بتبذل كل جهودها عشان تدعم منظومة الرعاية الصحية بكل إمكانياتها وبمجهودات شركائها من العاملين في الشركة. وبفضل الله قدرنا نساعد المرضى ووفرنا المعدات اللي تساعد في تشخيص حالتهم، تتابع علاجهم، وتساعد الأطباء في العمليات الجراحية والرعايات. والنهاردة إحنا لسه بنجدد التزامنا تجاه منظومة الصحة بتقديم أحدث النظم التشخيصية والعلاجية والدعم المستمر لكل شركائنا. صحة كل مريض هي محور اهتمامنا. دي الرسالة اللي بنؤمن بيها في غاليونجي من سنة 1979، الرسالة اللي خلتنا نبني شراكة مع كل العاملين في المجال الطبي ونتحالف مع أكبر الشركات العالمية عشان نواكب التطور اللي بيحصل في العالم ونقدم أفضل دعم للدكاترة وأفضل منتجات للرعاية الصحية. ولأننا في غاليونجي بنؤمن إن الرعاية الصحية من أهم عناصر التنمية المستدامة، كان لازم نعمل كل اللي نقدر عليه عشان نطور من نفسنا ونساهم في تطوير كل شركائنا في المجال الطبي في كل مكان في مصر، ندربهم ونساعدهم ونوفر لهم خدمات ما بعد البيع بصفة دائمة. من 40 سنة وغاليونجي بتبذل كل جهودها عشان تدعم منظومة الرعاية الصحية بكل إمكانياتها وبمجهودات شركائها من العاملين في الشركة. وبفضل الله قدرنا نساعد المرضى ووفرنا المعدات اللي تساعد في تشخيص حالتهم، تتابع علاجهم، وتساعد الأطباء في العمليات الجراحية والرعايات. والنهاردة إحنا لسه بنجدد التزامنا تجاه منظومة الصحة بتقديم أحدث النظم التشخيصية والعلاجية والدعم المستمر لكل شركائنا. صحة كل مريض هي محور اهتمامنا. دي الرسالة اللي بنؤمن بيها في غاليونجي من سنة 1979، الرسالة اللي خلتنا نبني شراكة مع كل العاملين في المجال الطبي ونتحالف مع أكبر الشركات العالمية عشان نواكب التطور اللي بيحصل في العالم ونقدم أفضل دعم للدكاترة وأفضل منتجات للرعاية الصحية. ولأننا في غاليونجي بنؤمن إن الرعاية الصحية من أهم عناصر التنمية المستدامة، كان لازم نعمل كل اللي نقدر عليه عشان نطور من نفسنا ونساهم في تطوير كل شركائنا في المجال الطبي في كل مكان في مصر، ندربهم ونساعدهم ونوفر لهم خدمات ما بعد البيع بصفة دائمة. من 40 سنة وغاليونجي بتبذل كل جهودها عشان تدعم منظومة الرعاية الصحية بكل إمكانياتها وبمجهودات شركائها من العاملين في الشركة. وبفضل الله قدرنا نساعد المرضى ووفرنا المعدات اللي تساعد في تشخيص حالتهم، تتابع علاجهم، وتساعد الأطباء في العمليات الجراحية والرعايات. والنهاردة إحنا لسه بنجدد التزامنا تجاه منظومة الصحة بتقديم أحدث النظم التشخيصية والعلاجية والدعم المستمر لكل شركائنا. صحة كل مريض هي محور اهتمامنا. دي الرسالة اللي بنؤمن بيها في غاليونجي من سنة 1979، الرسالة اللي خلتنا نبني شراكة مع كل العاملين في المجال الطبي ونتحالف مع أكبر الشركات العالمية عشان نواكب التطور اللي بيحصل في العالم ونقدم أفضل دعم للدكاترة وأفضل منتجات للرعاية الصحية. ولأننا في غاليونجي بنؤمن إن الرعاية الصحية من أهم عناصر التنمية المستدامة، كان لازم نعمل كل اللي نقدر عليه عشان نطور من نفسنا ونساهم في تطوير كل شركائنا في المجال الطبي في كل مكان في مصر، ندربهم ونساعدهم ونوفر لهم خدمات ما بعد البيع بصفة دائمة. من 40 سنة وغاليونجي بتبذل كل جهودها عشان تدعم منظومة الرعاية الصحية بكل إمكانياتها وبمجهودات شركائها من العاملين في الشركة. وبفضل الله قدرنا نساعد المرضى ووفرنا المعدات اللي تساعد في تشخيص حالتهم، تتابع علاجهم، وتساعد الأطباء في العمليات الجراحية والرعايات. والنهاردة احنا لسه بنجدد التزامنا تجاه منظومة الصحة بتقديم أحدث النظم التشخيصية والعلاجية والدعم المستمر لكل شركائنا. صحة كل مريض هي محور اهتمامنا. دي الرسالة اللي بنؤمن بيها في غاليونجي من سنة 1979، الرسالة اللي خلتنا نبني شراكة مع كل العاملين في المجال الطبي ونتحالف مع أكبر الشركات العالمية عشان نواكب التطور اللي بيحصل في العالم ونقدم أفضل دعم للدكاترة وأفضل منتجات للرعاية الصحية. ولأننا في غاليونجي بنؤمن إن الرعاية الصحية من أهم عناصر التنمية المستدامة، كان لازم نعمل كل اللي نقدر عليه عشان نطور من نفسنا ونساهم في تطوير كل شركائنا في المجال الطبي في كل مكان في مصر، ندربهم ونساعدهم ونوفر لهم خدمات ما بعد البيع بصفة دائمة. من 40 سنة وغاليونجي بتبذل كل جهودها عشان تدعم منظومة الرعاية الصحية بكل إمكانياتها وبمجهودات شركائها من العاملين في الشركة. وبفضل الله قدرنا نساعد المرضى ووفرنا المعدات اللي تساعد في تشخيص حالتهم، تتابع علاجهم، وتساعد الأطباء في العمليات الجراحية والرعايات. والنهاردة احنا لسه بنجدد التزامنا تجاه منظومة الصحة بتقديم أحدث النظم التشخيصية والعلاجية والدعم المستمر لكل شركائنا. صحة كل مريض هي محور اهتمامنا. دي الرسالة اللي بنؤمن بيها في غاليونجي من سنة 1979، الرسالة اللي خلتنا نبني شراكة مع كل العاملين في المجال الطبي ونتحالف مع أكبر الشركات العالمية عشان نواكب التطور اللي بيحصل في العالم ونقدم أفضل دعم للدكاترة وأفضل منتجات للرعاية الصحية. ولأننا في غاليونجي بنؤمن إن الرعاية الصحية من أهم عناصر التنمية المستدامة، كان لازم نعمل كل اللي نقدر عليه عشان نطور من نفسنا ونساهم في تطوير كل شركائنا في المجال الطبي في كل مكان في مصر، ندربهم ونساعدهم ونوفر لهم خدمات ما بعد البيع بصفة دائمة. من 40 سنة وغاليونجي بتبذل كل جهودها عشان تدعم منظومة الرعاية الصحية بكل إمكانياتها وبمجهودات شركائها من العاملين في الشركة. وبفضل الله قدرنا نساعد المرضى ووفرنا المعدات اللي تساعد في تشخيص حالتهم، تتابع علاجهم، وتساعد الأطباء في العمليات الجراحية والرعايات. والنهاردة احنا لسه بنجدد التزامنا تجاه منظومة الصحة بتقديم أحدث النظم التشخيصية والعلاجية والدعم المستمر لكل شركائنا. صحة كل مريض هي محور اهتمامنا. دي الرسالة اللي بنؤمن بيها في غاليونجي من سنة 1979. الرسالة اللي خلتنا نبني شراكة مع كل العاملين في المجال الطبي ونتحالف مع أكبر الشركات العالمية عشان نواكب التطور اللي بيحصل في العالم ونقدم أفضل دعم للدكاترة وأفضل منتجات للرعاية الصحية. ولأننا في غاليونجي بنؤمن إن الرعاية الصحية من أهم عناصر التنمية المستدامة، كان لازم نعمل كل اللي نقدر عليه عشان نطور من نفسنا ونساهم في تطوير كل شركائنا في المجال الطبي في كل مكان في مصر. ندربهم ونساعدهم ونوفر لهم خدمات ما بعد البيع بصفة دائمة. من 40 سنة وغاليونجي بتبذل كل جهودها عشان تدعم منظومة الرعاية الصحية بكل إمكانياتها وبمجهودات شركائها من العاملين في الشركة. وبفضل الله قدرنا نساعد المرضى ووفرنا المعدات اللي تساعد في تشخيص حالتهم، تتابع علاجهم، وتساعد الأطباء في العمليات الجراحية والرعايات. والنهاردة إحنا لسه بنجدد التزامنا تجاه منظومة الصحة بتقديم أحدث النظم التشخيصية والعلاجية والدعم المستمر لكل شركائنا. صحة كل مريض هي محور اهتمامنا. دي الرسالة اللي بنؤمن بيها في غاليونجي من سنة 1979. الرسالة اللي خلتنا نبني شراكة مع كل العاملين في المجال الطبي ونتحالف مع أكبر الشركات العالمية عشان نواكب التطور اللي بيحصل في العالم ونقدم أفضل دعم للدكاترة وأفضل منتجات للرعاية الصحية. ولأننا في غاليونجي بنؤمن إن الرعاية الصحية من أهم عناصر التنمية المستدامة، كان لازم نعمل كل اللي نقدر عليه عشان نطور من نفسنا ونساهم في تطوير كل شركائنا في المجال الطبي في كل مكان في مصر. ندربهم ونساعدهم ونوفر لهم خدمات ما بعد البيع بصفة دائمة. من 40 سنة وغاليونجي بتبذل كل جهودها عشان تدعم منظومة الرعاية الصحية بكل إمكانياتها وبمجهودات شركائها من العاملين في الشركة. وبفضل الله قدرنا نساعد المرضى ووفرنا المعدات اللي تساعد في تشخيص حالتهم، تتابع علاجهم، وتساعد الأطباء في العمليات الجراحية والرعايات. والنهاردة إحنا لسه بنجدد التزامنا تجاه منظومة الصحة بتقديم أحدث النظم التشخيصية والعلاجية والدعم المستمر لكل شركائنا. صحة كل مريض هي محور اهتمامنا. دي الرسالة اللي بنؤمن بيها في غاليونجي من سنة 1979. الرسالة اللي خلتنا نبني شراكة مع كل العاملين في المجال الطبي ونتحالف مع أكبر الشركات العالمية عشان نواكب التطور اللي بيحصل في العالم ونقدم أفضل دعم للدكاترة وأفضل منتجات للرعاية الصحية. ولأننا في غاليونجي بنؤمن إن الرعاية الصحية من أهم عناصر التنمية المستدامة، كان لازم نعمل كل اللي نقدر عليه عشان نطور من نفسنا ونساهم في تطوير كل شركائنا في المجال الطبي في كل مكان في مصر. ندربهم ونساعدهم ونوفر لهم خدمات ما بعد البيع بصفة دائمة. من 40 سنة وغاليونجي بتبذل كل جهودها عشان تدعم منظومة الرعاية الصحية بكل إمكانياتها وبمجهودات شركائها من العاملين في الشركة. وبفضل الله قدرنا نساعد المرضى ووفرنا المعدات اللي تساعد في تشخيص حالتهم، تتابع علاجهم، وتساعد الأطباء في العمليات الجراحية والرعايات. والنهاردة إحنا لسه بنجدد التزامنا تجاه منظومة الصحة بتقديم أحدث النظم التشخيصية والعلاجية والدعم المستمر لكل شركائنا. صحة كل مريض هي محور اهتمامنا. دي الرسالة اللي بنؤمن بيها في غاليونجي من سنة 1979. الرسالة اللي خلتنا نبني شراكة مع كل العاملين في المجال الطبي ونتحالف مع أكبر الشركات العالمية عشان نواكب التطور اللي بيحصل في العالم ونقدم أفضل دعم للدكاترة وأفضل منتجات للرعاية الصحية. ولأننا في غاليونجي بنؤمن إن الرعاية الصحية من أهم عناصر التنمية المستدامة، كان لازم نعمل كل اللي نقدر عليه عشان نطور من نفسنا ونساهم في تطوير كل شركائنا في المجال الطبي في كل مكان في مصر. ندربهم ونساعدهم ونوفر لهم خدمات ما بعد البيع بصفة دائمة. من 40 سنة وغاليونجي بتبذل كل جهودها عشان تدعم منظومة الرعاية الصحية بكل إمكانياتها وبمجهودات شركائها من العاملين في الشركة. وبفضل الله قدرنا نساعد المرضى ووفرنا المعدات اللي تساعد في تشخيص حالتهم، تتابع علاجهم، وتساعد الأطباء في العمليات الجراحية والرعايات. والنهاردة إحنا لسه بنجدد التزامنا تجاه منظومة الصحة بتقديم أحدث النظم التشخيصية والعلاجية والدعم المستمر لكل شركائنا. صحة كل مريض هي محور اهتمامنا. دي الرسالة اللي بنؤمن بيها في غاليونجي من سنة 1979. الرسالة اللي خلتنا نبني شراكة مع كل العاملين في المجال الطبي ونتحالف مع أكبر الشركات العالمية عشان نواكب التطور اللي بيحصل في العالم ونقدم أفضل دعم للدكاترة وأفضل منتجات للرعاية الصحية. ولأننا في غاليونجي بنؤمن إن الرعاية الصحية من أهم عناصر التنمية المستدامة، كان لازم نعمل كل اللي نقدر عليه عشان نطور من نفسنا ونساهم في تطوير كل شركائنا في المجال الطبي في كل مكان في مصر. ندربهم ونساعدهم ونوفر لهم خدمات ما بعد البيع بصفة
دكتور احمد، دكتور احمد او حد من العمليات.
ايه يا دكتور؟
احنا مستنيين ايه؟
بنجهز بس يا دكتور في التجهيزات، دقايق ونبدا على طول.
دقايق 10 دقايق يعني؟
دكتور احمد عبد الرؤوف يا فندم مع حضرتك.
سامعني يا حسام؟
سامعك يا دكتور.
طيب احنا هنبدا دلوقتي على طول، يعني خلاص تعاوننا وجاهزين ان شاء الله. ابدا.
طيب.
اعرض بس التفاصيل بتاعه الحاله، خلي محمود يقدم الحاله وخلاص الحاله نمت هنبدا حالا.
ماشي، هو صوت حضرتك بعيد بس.
سامعني كده؟
كده كويس.
خلاص نقدم بس الحاله كده الاول، الداتا بتاعتها، وهننقل على طول بعد ما تقدموا الحاله.
طيب.
ما انا فاهم. طب ما
ممكن نبدا نقدم الحاله بعد اذن حضراتكم القاعه.
السلام عليكم.
صباح النور دكتور حسام او دكتور محمود. احمد
أيوة.
الصباح معاكم. احنا قدامنا
أحمد.
باذن الله 5 دقايق، يعني لو if you wanna start and present the case.
طب ما هات لي بس كده، هو الدكتور احمد عبد الرؤوف فين يا شباب؟
دكتور احمد جوه العمليات يا فندم.
طب ماشي، حد بس البرزنتيشن مش ظاهر على الشاشه.
ماشي يا فندم، حضرتك ابدا يا فندم، هيظهر على الشاشه.
ما احنا خلاص بدانا اهو احنا.
اتفضل يا دكتور ابدا.
طب تمام. السلام عليكم. هو today's case الدكتور اندرو هيشتغلها، هي left loop HCC. هو 55 year old male patient accidentally discovered left loop mass. Medical history only hypertension and no history of previous operations. For the lab investigation, his CTP score A. All the investigations are within normal range, except only for the serum alpha fetoprotein more than 2,000 nanogram per milliliter, and he is HCV positive. For the triphasic CT, he has a cirrhotic liver with periportal fibrosis, and he has segment 3 HCC 3 by 4.5 by 4 centimeter in diameter. Upper GI endoscopy, nothing except congestive gastropathy. And he is prepared for left lateral segmentectomy, laparoscopic left lateral segmentectomy. شكرا.
The other case is a case of reflux. 51-year-old female patient complaining of heartburn and typical reflux symptoms for the last 6 months with poor response to BBI. She was diagnosed based on clinical radiology and endoscopy. Endoscopy revealed wide incompetent cardia with prolapsing gastric mucosa and small hiatus hernia, and barium meal revealed sliding hiatus hernia.
a smaller.
اللي معانا من العمليات دكتور الصباغ ولا دكتور احمد؟
Perfect. So, I mean, I can try with this.
دكتور اندرو.
Yes. Hello. I'm just waiting for an 11 blade because I like to use the Varus needle on my patients when I start.
Can you show us the patient positioning?
Sure.
Before incision?
Yeah. What can you see? Let me see. So I have the patient in the French position, which is really why I like laparoscopy, which is why the robot is nice but not fundamental. You know, obviously when you do surgery in the pelvis, I can't sit here, so the robot is very good for that. But for upper abdominal work, I like the French position with the legs spread. And I'm just going to start here with the varus needle. The safest place, of course, is Palmer's Point, but the only thing I worry about when I do a liver is if I hit the gallbladder. So if I hit the gallbladder with the varus needle, I'll just take out the gallbladder. It's not a big problem because I want to put my trocar here to retract the liver. Any luck? All right, so we're going to try, even though I normally use an 11 blade. Let's see if I can make a small incision. I do it right on the liver because that makes it as tight as possible. I need a syringe with 10 cc's of saline. Let's see if I can break through the skin. I think I did. I'm not sure. Yeah, okay. So thank you. So we do a drop test when we do the varus needle. This is actually there. I think it felt good. So I aspirate first, then I inject, and the water falls nicely. So I attach the pneumoperitoneum, and away we go.
Is this the routine start point for insufflation in your practice?
Yes, I use varus needle every time, almost every time.
From the right hypochondrium?
For liver surgery, yes. If I have a patient which is a little more difficult, I'll do it on the left side. But if I'm doing liver surgery, I'll start in that area, yes. It's okay. Pressure is good.
So why don't you use it on the left side always?
Because I want to put a trocar here.
Uh-huh.
I don't want to put a trocar over here where I would put the varus needle.
Okay.
But I don't think it's not a problem. If you want to do it on the left side, it's safer in general. There's no problem. In the beginning, when you use varus needle, I think it's smarter to do it at Palmer's Point on the left side. In America, we had a few patients where the varus needle went into the inferior vena cava, massive air embolism, and patient ended up dying. Not one of mine, but at work, it happened at a hospital I used to work at. Young woman died. So by all means, use the left side.
Because always, yes, when we go outside the umbilicus, we use the left side, not the right side, the left hypochondrium.
And what happens if you have previous surgery in the left upper quadrant?
In the previous surgery, no, we just go with optical trocar or open method away from it.
I use the right side about 95% of the time, no problem. The only thing I'm worried about is if I get into the gallbladder. But like I said, if I'm planning on maybe taking the gallbladder, and this is a case I might plan on taking the gallbladder, depending on what I find, then I use the right side.
Okay.
I don't think it's that important, though. So we're just waiting. So pneumoperitoneum, I like to keep it at 15 for liver surgery, but you can go as high as 20. And I hope this is a liver center, and we told the anesthesiologist to keep the patient as dry as possible. Good, perfect, excellent. Do you have a pen? I'll maybe draw the type of incisions we're going to do. Pen? No? It's okay, no problem. No problem. A lot of surgeons don't have patience for the varus needle, which is why I think they like to do the open technique. No, we already have one open. It's fine. It's already open. Yeah, it's okay. It doesn't make it. It's not worth it to open up another one. No. She's correct. I prefer the curve, but it's already open. It's fine. It's fine. No. Oh, if we need it, we will. We'll start with the. Yeah. We have the harmonicas curved already, so it's fine. So actually. Do they have a laparoscopic 10 millimeter ligature? 10 millimeter ligature. Because the 10 millimeter ligature works better on cirrhotics. Like when you do open surgery. I don't know if you noticed that the 10 works better than the 5 millimeter. So we used to call the 10 millimeter the Atlas. I don't know if they even make it anymore. Don't have it? Okay. It's not available anymore? Yeah. Okay. All right, so I think we'll go about here. Yeah, can I have a pen or a knife, please? I'm going to go about here. Well, yeah, you're going to be a little bit more over here. You're going to be even. I do one hand breath under the ribs. Here, I'm not really sure, so I'm doing a little bit lower just to make sure I'm not too high because it's just the left lateral. So I usually like to do this. Yeah. You can see it looks like he already has a little bit of portal hypertension, even in by the rate of the bleeding. So I like to see. Let me see if I see anything.
اللي قلنا كده على الشاشة تمام.
Yes, I like to use 30 degrees. I'm probably in the falciform here, yeah. So I use 30 degree all the time. So yeah, leave the Verus needle inside. I like to check the position of the Verus needle. Let me have this. That's it. Okay, so got to push in a little bit further. All right, so I like to check the position of the Verus needle. That is not, I guess, that is a liver only a mother could love, as we say. So let's see where the Verus needle is. Here it is. It's not in anything special, so it comes out. So
Dr. Andrew, the camera port is in the midline or slightly to the left or the right?
I did it right in the midline. So this looks like some kind of, it's PET negative. The other side, they look similar, I must admit. Well, this is the one on the right side that remember we saw, but it's PET negative. And then over, but it looks the same. So we could do a biopsy. Yeah, it's the segment 3. And then here's the other tumor probably. Okay. Can I get some reverse Trendelenburg, please? So this is important. If I were to look here, I don't know if you can see this. Can you show the outside view for a second?
We are seeing the outside view.
You see the outside view? Okay. So if I were to look at this while it were going in, and if I put the trocar in, when I remove this torque, this will end up sitting like this. So I put that in blindly. I don't know if you noticed, but I put it in without looking at it. It's just a small little trick, but it'll make your life a little bit easier. All right, so let me get a grasper, please. Do we have anything to heat up the camera? So I didn't look when I put this trocar in, because if I pulled this over and I put this in, once this goes back to its normal position, the fascia will move this so it'll sit like this. Ah, beautiful. Okay. So, okay. So I think this is a nice transection point. Let's put a 5 here. We already have an incision. And is this patient, is this HCC treated? Is he still positive? Or is he successfully treated for his HCC? So he's no longer positive. Yeah. Okay.
As you know, there's a contraindication to give antiviral.
What is?
If it is an active tumor, it is a contraindication.
Yeah, no, that's why, no, I wonder if he was treated beforehand.
Antiviral before.
Yeah, okay. So we can't really see anything on the underside. Do we have an ultrasound?
Yes.
All right, so let's look over here now. So I think we'll go around about here. Yeah, no problem. I remember it very well. I think this is the one I have in the public hospital in France. He's still positive? Okay. I want to know how careful to be with instruments. So I think if we can get rid of the scalpels, if they can put them on the side, thank you. Okay, great. Okay, let's heat it up again. So do we have a biopsy needle? Can we send a frozen section, or? Because if we can get a biopsy needle, we'll send a frozen section of. So move the insufflation to this over here. All right. So let's do the ultrasound.
Can you switch the camera to the sonar?
To what?
To the ultrasonic view?
I'm not sure if we can.
The camera on the abdominal wall can be switched to the ultrasound.
Like this, maybe?
Yes. On the abdominal wall, the camera on the abdominal wall.
I can't see what I'm doing now. Yeah.
يا جماعة
I see,
الكاميرا اللي على بطن العيان بس لو نحطها على السونار لو نوجهها لشاشة السونار.
Not very,
دكتور محمد الشوبري.
very echogenic.
دكتور محمد محتاجين نشوف الصورة ولو حضرتك تشرح لنا برضه دكتور محمد الفايند.
Has alpha fetoprotein more than 2,000.
So I think we can see the outside of the tumor, but ultrasound is not really giving us a lot of wonderful information. I must. Yeah, but when we look at the CT on the MRI, the tumor is here.
Yes.
It's much more lateral. So this we saw.
This is the tumor. Yes. No.
This one, I think.
No, this is I think this is fibrosis portal vein. You can put ultrasound.
No, but this is
the tumor.
You think?
Yes, this is the tumor. Yes.
But I think this is the thing that, remember I told you we saw something?
No,
on
if
the
you
right side?
see, this is the tumor.
All right, well, so if this is the tumor, I don't even need to do a left lateral. I'm just going to take this. I'm just going to take segment 3. Yeah, no, trust me, I'm looking. We're going to look on the right side also. But if that's the tumor, I'm just going to take segment 3.
Yes, this is the tumor, yes. You can map with ultrasound.
Yeah, yeah.
I see with you. Okay.
No, here, hold the camera. Hold the camera. Hold the camera. I'm going to try to do it from the underside, see if that helps. Why not? Do we have a... Let's see, hold on. Yeah, 1 sec. Is it the same camera? Let me do an ultrasound first. Hold on,
Yes.
let's see.
Yes, this is the tumor.
I know.
Professor
I
Andrew.
don't understand what's going
Now
on.
we see the tumor by ultrasound. Okay. Here it is.
Yeah.
This is the left portal branch.
دكتور شوبري ممكن الكاميرا تيجي على السونار؟
الكاميرا هنا يا جماعة.
Yeah, but it's not correlating with the preoperative imaging. This, remember I was showing you something that was more medial?
أشعة فين بتاعت العيان.
I think this is the one. This is really bizarre. Well, maybe, yeah, I see. Maybe it is the correct. Isn't that strange, though? Because it looks... Yeah, well, I'm not really... I mean, clearly we're going to remove that thing in segment 3. But here, I'm not really finding anything here. Let's look over here.
If you see the imaging,
Yeah,
see here the imaging.
yeah,
If you came up and down,
yeah,
segment 2,
yeah, clean.
there is nothing.
Yeah, 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 no, I
It
agree.
is in segment 3 down. Is there the positioning here?
Yeah, 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 yeah.
We here, if you see this image,
Yeah, it makes sense now. You're right, you're right.
okay, we go down.
Yeah,
see
yeah, yeah,
segment
yeah, yeah,
3,
yeah, yeah, yeah.
Not in segment 2.
So this is ICG? So ICG, I
You
think...
see
the
this
two-
one? This image?
Yeah, 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 yeah. Yep, yep, yep. It makes sense now. But we just need to remove segment 3 then.
But we have to see segment.
What about the right lobe, Dr. Andrew?
Yeah,
can't
we're
see
going to look at the
right
right lobe now. So,
Segment 4, I want to see segment 4 as well. Segment 4.
here, hold the camera. Thank you. But we're going to look at that lesion we saw, that PET positive image,
Yes.
in a second.
We don't have any lesions here.
Well, remember the PET scan had a very hot image, remember? I just want to look, make sure there's nothing that we're missing obvious.
This one, you can see 1 minute. What's this one?
This is just fat, it looks like.
It's fat, yes.
I think it's just fat. The image, the lesion was over here, and the
don't
parenchyma
have
looks
anything,
pretty
yes.
clean.
I think this is only this image only. segment
Yeah,
3,
I think
yes.
we're good. I think we're good. Okay. So the ICG isn't helping us too much, but I think it had to be given several hours before, at least an hour before, because as you can see, the tumor isn't lighting up. So I think ICG has to give usually the night before.
The night before.
Yeah, yeah. Unfortunately, we just gave this maybe, 45 minutes ago? Yeah. Yeah, so it has to be, I think, at least 8 hours before. I was hoping the reps could have helped us with that because every dose is a little bit different. But anyway, that's why it's not lighting up. But I think that's okay.
What's your plan?
So I'm going to just start to do removal of segment 3. We'll do like a partial left lateral resection.
But if we take in the data of the patient,
Yeah.
we have alpha fetoprotein more than 2,000.
Yeah.
Then I think there is vascular invasion in the portal vein. So in this area, if we think alpha fetoprotein is high,
Yeah.
so this tumor is near the portal branch.
Yes.
So my opinion is to do complete left lateral to be more radical.
No, I'm more worried about liver failure, and I'm more worried about him developing more tumors.
Yes.
And not having, he needs liver in the future for us to resect. If we are more radical, it just increases his risk of liver failure with no benefit. We just need a negative margin. I don't think more will help. I mean,
Yes.
Yeah, yeah. Yeah, I'm always worried about liver failure. And look at all this healthy liver that we can leave him.
So I are planning to do segment 3 only.
Yeah, and it'll probably be non-anatomic. It's not even going to be an anatomic. It'll just be like
Atypical resection.
like atypical resection. I think so. That's what I would vote for.
Okay.
If you guys want to outvote me, we can. Yeah, I think so.
So, Dr. Andrew, you prefer smaller margins to preserve the liver function and also for the
Absolutely.
and also for next resections if he is suitable for if he has recurrence and have further resections.
Exactly. So we don't burn any bridges.
Okay.
Excuse me, Dr. Andrew.
Yeah.
What the limit of safety margin you prefer for HCC?
I
for
usually
resection?
go for around 1 centimeter.
Around 1 centimeter.
Below this.
Okay, thank you.
So so even though I put it low, it's still, you know what, I'm going to change the angle of this. Can I have the introducer here? I need the thing that goes here. I'm going to change the angle of this. Because the left side is so big that I'm actually going to put this in a little bit lower. Okay, let's see if that gets us a little more real estate. Can I have the bipolar, or still not ready? Yeah. Because there's something we need to do with the bipolar for this ligament in our face. Actually, it looks like we're better off here. Is the regular bipolar ready? I need the real bipolar.
Will be ready within
5 minutes?
5 minutes.
Okay. Because unfortunately, I use the bipolar, hold the camera. I use the bipolar in this situation to burn the round ligament, so it'll get out of our face. So I think he needs, can he have something that locks here so we can hold this up? Like a locking? Okay. Actually, you know what? Let me try if you... No, it's for to burn the fat so that it shrinks from our face, you have to use the bipolar. All right, hold this. Maybe like, oops. Hold on.
But also it can be done with a monopolar, burning the fat.
Yeah, you can. I just like to do it with the bipolar. Everyone's, you know. All right. So unfortunately, it's hard for me to continue right now without the bipolar, because if I get bleeding, I am screwed, right? So I'm really I'm kind of stuck waiting for the bipolar. It's
bipolar, yalla.
It is the most, no, I can wait. It's just that it's the most important device. Because if I have uncontrolled bleeding, you know, we have to open. So, yeah, so I think we have to wait. I apologize, but. No problem. So, you know, I think we're just going to do something like this, really.
Okay. A typical resection.
Yeah. I think we're going to take off the first centimeter anteriorly here. Then we're going to take it posteriorly. And then we're going to fire a stapler here. And then we're going to fire a stapler here. And maybe 2 staplers here, and we're done.
Okay.
So, yeah, I'm tempted, but if it bleeds, we're screwed. Yeah.
It comes.
No problem. I guess we might as well keep doing the ultrasound. Since we have the time, we can spend more time on the ultrasound. Let's see if we find any other surprises.
هو الدكتور احمد عبد الرؤوف بدأ حالة الفندوبلايكيشن ولا لسه؟
Fundoplication? What?
There is another case yes, of fundoplication in the other room.
Okay, yeah, you can go ahead there.
Okay, I will be with you.
Yeah, I really don't see anything here. Remember, we saw something medially. Let's look more medially. Just remember, make sure there's nothing here.
There is nothing.
بعد اذن حضرتك يا دكتور هنرجع للدكتور احمد عبد الرؤوف.
السلام عليكم دكتور احمد. حضرتك خلصت خلاص.
Here is the portal vessels.
Yeah, they're very posterior.
دكتور احمد.
ايوه معاك يا محمود سامعني؟
هو
هو
العين نازل بالغرز من فوق ولا ايه؟
لا واحنا بدأنا بس على بال انا سايبكم بس تو انجوي دكتور اندرو، بس يعني هوريك احنا عملنا ايه.
طيب تمام.
هي الحالة دي عيانة عندها 50 years وفيها ريفلكس وهيتس هيرنيا بالمنظار وبالباريوم. احنا بدأنا ديسكشن، ارفع كده يا درويش. بدأنا ديسكشن. This is an off segment of the esophagus زي ما احنا شايفين، وده الريبير اللي احنا عاملينه في الكراس. I think 2 stitches are enough. It's tight enough. لكن انا شايف بعد ما عملت الهيتا ريبير ده ان الغرز بتاعتي مشدوده شويه، فانا بفكر اعمل تنشن ريليسنج ريلاكسنج انسيجن.
تمام.
فهبدا اعمل ريلاكسنج انسيجن في الكراس. انا بتصحى عشان اعمل ريليز على التنشن على الغرز دي زي اي
هو يا دكتور احمد بعد اذنك، هو الكارديو اسوفيجيال جانكشن مش واضح عندنا في الصوره هنا.
هوريهولك حالا.
هو دكتور احمد الريلاكسنج انسيجنز يعني مش الافضل نعملها قبل ولا بعد الريبير؟
لو انت قبل الريبير متوقع انك هتعمل ريبير بدون تنشن مش لازم تعمله، لكن بعد ما خدت الغرز وشفت ان هي ممكن تبقى اندر تنشن زي ما انا شفت كده ممكن تعمله.
طب ممكن يا دكتور احمد تشرح لنا بس انت بدات التنشن ريليز انسيجن منين بالظبط واللاند ماركس بتاعتك؟
انا يعني ببص على الاي في سي زي ما انت شايف، ده الاي في سي اهو، ده الكوديت لوب اوف ذا ليفر اند ذس از اي في سي. المفروض اتليست يكون 1 سنتيمتر هو ميد واي بتوين دي سويتشر لاين بتاعك وما بين الاي في سي، او على الاقل 1 سنتيمتر فروم يور ريبير.
تمام.
بفتح البريتونيال كفر بتاع الكراس، رايت كراس اللي موجود ده يوجوال على الرايت سايد لحد ما اوصل، يعني ممكن افتح البلوره. انت شايف البلوره اهي، البلوره ذس از ا بلوره، وبعمل لونجتيودنال انسيجن. مش لازم انزل تحت قوي، يعني لو نزلت تحت هنا في انجري ممكن اعور الثوراسيك داكت، فلازم يكون مش تحت قوي.
طب وفوق بنوصل لغايه فين؟
لحد ما تحس ان التنشن بتاعك بقى ريليزد.
تمام.
طيب لو فتحت البلوره هنعمل ايه يا دكتور؟
نو بروبلم.
ايوه يعني نو بروبلم، هنحط درين ولا التعامل هيكون ازاي؟
ولا تعمل اي حاجه، مفيش اي مشكله خالص. انت بتحط ده كربون دايوكسيد فمفيش منه مشكله. اشوف كده يعني اي ثينك كده اناف. بالبلور اهي، وادي الريبير بتاعي مفيش تنشن عليه خالص. I think this is safeguard against recurrent hernia. اشوفه كده من هنا كده.
هو في سؤال من الفلورا يا دكتور احمد، لو البلوره اتفتحت هيحصل اير ليك للميدياستاينم والبلورال كافيتي؟
مش اير ليك، كربون دايوكسيد ليك.
كربون دايوكسيد.
كربون دايوكسيد ليك is of no consequences، مفيش اي مشكله خالص. I think enough كده الريبير بتاعي معقول.
طيب احنا عايزين نشوف الكارديا.
الكارديا بتعرفها بالتاب بتاعك. وريني كده، شوف وريني التيب، ارجع كده. شايف التيب ده اللي انا لفه ده؟ This is the cardiovascular junction، باينه خالص اهي. اوريك النيرفز اللي موجوده. This is the posterior vagus nerve اهو معايا في الغرز. ادخل يا خالد. باين؟ This is the posterior vagus nerve. الانتيريور نشوفه. ساعدنا درويش عشان نشوفه. And this is the anterior vagus nerve.
ممكن بالتالي ما اعرفش اكمل عمليه.
اوكي. انا طبعا عملت ديفيجن للشورت جاستريكس.
ما بيعملش مشكله. فانا بتكلم في حاله
انا محتاج اهم حاجه عندي ان يكون في اناف سيجمنت موجوده وزاد تنشن. تشدش يا احمد، ما تشدش. زي ما انت شايف في سيجمنت كويسه من الاسوفجاس نازله تحت، كراس مقفوله كويس ومعمول ريليزنج انسيجن، فما فيش تنشن موجود عندي. انا دلوقتي اللي انا هعمله ان انا هعمل الريبير بتاعي اللي هو الفاندو بلاكيشن. الناحيه الثانيه يا احمد. باخد الهايست بوينت اللي موجوده في الفندس اوف ذا ستومك، هعدي الاله بتاعتي من ورا، وادخل وهمسك الفندس اوف ذا ستومك والفها حوالين المعده واطمن ان هي في روم اناف كويسه ومفيش تويست موجود فيها. زي ما انت شايف كده دي سيز اناف.
حضرتك بتعمل الراب على بوجي؟
لا. عايز ورث. انا كده مش شادد، فتعرف ان هو نوت اندر تنشن. هبدا اعمل الريبير بتاعي بالطريقه اللي هي شورت فلوبي فاندوبلاكيشن.
هو حضرتك معلش تاني ما بتحطش بوجي خالص؟
لا 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 لا.
في اي خطوه من الخطوات، ولا بتطمن مثلا على اساس ان الراب مش تايت او الكورونا ريبير مش تايت؟
لا لا لا، مش محتاج البوجي. البوجي يمكن مشاكله اكتر من فايده. اولا
تمام.
بيضايقك في الديسكشن، وطبعا في ريبورتد كيسز اوف بيرفوريشن هيتروجينيك انجري.
تمام.
فلا ملوش لازمه.
هو كان بمناسبه قصه البلورا دي، كانت يعني نصيحه من كارديو ثوراسيك سيرجن. يعني هو بيقول على حسب الفيلد في الابدومن، لو الفيلد بلادي يعني في ديسكشن كتير والفيلد بلادي، لا الاحسن ان احنا نحط شيست تيوب، على اساس ان هو بالنيجاتيف سكشن كل الفلويد والبلاد اللي موجود في الابدومن اللي هيكون ريمين هيطلع فوق، وممكن يعمل بلورال افيوجن يعني وهيموثوركس.
ممكن.
انما لو الفيلد دراي كده زي ما حضرتك شغال دلوقتي، لا مش لازم، ده هو CO2 يعني.
هو بس مضايقني الآلة بتاعت الشمال دي داخله عينه اوبيز بصراحه يعني البي ام بتاعها حوالي 45. فمضايقني الآلة الشمال.
ما هو
انقل بقى على الناحيه الثانيه.
دكتور
انا
أحمد.
هاخد بس عشان تنقل على الاوضه الثانيه، بس هفهمك انا هعمل ايه. انا هاخد الغرزه الاولانيه دي ما باخدهاش في الاسوفجاس، الغرزه الثانيه باخد فيها الاسوفجاس عند الكارديوسوفيجيال جانكشن، وابقى خلصت العمليه بتاعتي.
وحضرتك يا دكتور احمد بتثبت الراب في الاسوفيجاس ولا لا؟
بثبت الغرزه الثانيه مش الاولانيه.
طب بتثبتها في الكراس او في حاجه ثانيه ولا
لا لا لا
بتثبتها
لا
في
لا
الأسوفيجاس
لا
بس؟
لا 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 ما بثبتش في حاجه.
طيب دكتور احمد، لو سمحت حضرتك في التشخيص بتعتمد على الاندوسكوب والباريوم فقط، مش محتاجين نعمل BH او مانومتري؟
محتاجها في حالات معينه، يعني بحتاج البي اتش في حالات لو اكسترا اسوفيجيال مانيفستيشنز، لو نون ريسبوندنج للبي بي اي، او لو ايم ان داوت مش متاكد من التشخيص بتاعي. غير كده لا انا مش محتاجه.
طيب
موتيليتي دورها قليل قوي.
طب انا هعمل كومبليت راب او بارشل راب اكوردنج تو وات، اذا كنت انا مش عارف الاسوفيجيال موتيليتي اخبارها ايه ازاي؟
ما بتفرقش في النتائج بتاعتها، حتى لو في ويك اسوفيجيال موتيليتي ما بتفرقش النتائج بتاعتنا خالص. فما عادش، كان زمان في اللي هو فكره التيلورنج دي، لكن دلوقتي لا، الموضوع ده يعني سواء تعمل ده او ده، الاسوفيجيال موتيليتي ما بتفرقش معاك بصراحه في الريبير بتاعك.
طيب لو الريفلكس بتاعي الكلاين، في اي خطوه زياده حضرتك بتعملها في العمليه ولا؟
لا لا، نفس الستبس هياها لو الكلاين ريفلكس.
في رول للجاستروجينوستومي طيب لو في الكلاين ريفلكس؟
في رول؟ لا لا.
شكرا.
انا بثبت كده في ننقل بقى.
دكتور اندرو we are with you.
Okay, hello. We started the resection of Glissen's capsule. I'd like to very quickly utilize a hemostatic agent. I just stick it in there as I'm working. And then there was a little bit of oozing that's pretty much stopped, but I just like to show you that it's a nice little friend to have here when you're doing it laparoscopic. Even when you're doing it open, I use this often. I'll just put it in and then I'll move it as needed. So as you can see, this is the kind of line that we want to do here. So we're going to just continue the anterior cutting of Glissen's capsule. Let's see, am I in yet? Yes.
So it's not.
Sorry?
It's not routine for you to prepare Pringles just in case of bleeding, or not a routine step?
Not anymore. Not anymore. No. I can do it with an umbilical tape if you want, but this is a minor hepatectomy, so it's really not worth it for me. But by all means, if you want me to show you how to do it, I will do it.
Okay.
Again, my goal here is just to cut Glissen's capsule. The first centimeter, as we know, does not have very big blood vessels.
So if you have time, just show us your procedure of Pringles.
Okay.
Okay.
Let me just finish here. Okay. All right. So let's look under. All right. So, all right, pull down. Okay, you're going to hold the liver up like this. Okay. So, okay. Okay, so we're going to look under here. So you have to change the angle like this. Okay, hold it like that. All right, so we're just looking for the pars lucida of the lesser sac. And this is why I like to, we luckily we fixed it so I can grab a little bit. So you cut here. You expose the patoduodenal ligament. You sure you don't want to come under me? Here, I think it's easier for you, no? Yeah. Okay, good. All right. You can, this is why it's better if this bipolar closes so you can use it as a grasper, otherwise you're kind of screwed. Excuse my French. So again, just taking the patoduodenal ligament fat pad. So still looks like it's covered in fat here. Looks like there's another. Yeah, if only this would grasp. Depressing, it won't grasp. Oof. I don't know if they could fix these so I can use it actually as an instrument. And well, yeah, but it's just going to slow us down if I have to keep changing every time. You know, that's why it's nice when it actually works as a forceps and not just as a defensive weapon. So this is okay. So you would think we're all the way through here. All right, so it looks like we're around. Looks like a big lymph node there. Maybe? No, that's just Spigelian ligament, Spigelian lobe. Who knows? We don't really care. All right, so look over here on the other side. So now I would just pass an umbilical tape around here. So I'll take an umbilical tape, please.
Tape, يا أولاد. Would you like which type of tape?
This umbilical tape is what I use. Okay, scissors. I cut it about here. Yeah, okay. So I'll take 2 graspers now. Yeah, 1 and 2. All right.
You want to prepare for Bringham if you want?
Yeah, I'm just putting an umbilical tape around the patoduodenal ligament, and this way. Now, the reason I don't like this is I worry about forgetting to remove this at the end of the case, right? So because this is so you have to really tell your nurses, and then that we cut it, because what they will do is once they cut it, if they don't make a note, they will count the cut umbilical tape, and they will forget that they have to measure the umbilical tape at the end of the case, and they should measure it before they give it to me, and it has to be the same size at the end. You know, I know it seems foolish, but it can certainly happen. So let's see, are we seeing it? So come in with the camera a little bit. Not yet, not yet. So let's go back. Let's push it in a little bit more.
Demonstration.
That's nice. Thank you. Thank you very much. No. Honestly, sometimes I don't do it for right hepatectomies anymore either, because I find this kind of an annoying part of the procedure, to be honest. But I think in the beginning, it makes you feel good. There's nothing wrong with doing it. But you know, sticking an instrument back here like this is not fun. You know, it's doable, especially when you know you're not going to do it. And let's go back. That's nice with the camera. Nice camera work. All right, come in with the camera a little bit more. See, you got to really show me. Yeah, can you change the angle a little bit more? Yeah, you can really show me well with that 30 degrees. Okay, let's see. Let's see if that did the trick. Oh, I keep pulling it back. So usually when I do a major hepatectomy, I dissect out the entire hepatoduodenal ligament. So I expose the portal vein and the artery, and then I do the Pringle, right? So this, I don't want to have to dissect all of those structures because I'm not doing it, so it's a little bit more difficult. But when you do a major hepatectomy, this is a lot easier because it's already skeletonized. So then, yes, I do. So here we go. So then I do a double knot. I put some clips on it. And then if I have a problem, I just pull up on the two ends and I can do a Pringle. So it's pretty painless. So once, do a surgeon's knot. Twice. Made it a little bit short. I made it a little bit short, but it's okay. Okay. So that's it. So if need be, clip. And this is just to keep it in place. I usually put 2 clips. I think in this situation I'll just do 1, okay? So if need be, you're all good to go now. Okay, let's get the bipolar back. Here it is, great, yep. Okay, so I think we did the anterior part. Let's look posterior now. Oops. So, okay, now we can lower this down. Okay, you're going to grab this. Oh, so you know what? Let's see if we can do this now. Where is, here. No, I'm going to keep these. Oh, actually, I'm going to take these from here. I'm just going to try to deal with this ligament. Okay, here we go. Oop, who's fighting me? Maybe here's better. Let's see. So it just helps retract it. I know you can do it with the monopolar too. Now we can see things a little bit better. This bipolar isn't opening all the way up, so I can't do a bigger burn, but it's better than nothing. Whew, that really doesn't want to open. I keep it, you know, if it were really bothering me, I would cut it now, but it's not really bothering me. So. Yeah, I usually do. It helps to hold up the liver. You know, if this were really annoying me, I would cut it right here. And, you know, I might just so that people can see it a little bit better because the bipolar isn't working very well with that. So we want to get it as high as possible because the thing on the top is what's annoying me and not anything else. So let's go way up here. So pull back the camera. Otherwise, it's going to get dirty. Just the camera. Pull back. Yep, that's it. I'm only going to cut the round ligament and not the falciform ligament. Yeah, come in a little bit with the camera so I can see. Yeah. Yeah, you might have to clean the camera. Well, we'll keep going. It's okay. let's see if this helps. Okay, do one more little bite. Okay, all right, so I think the viewers are happier now, okay? Okay, so let's do the underside. Let me get the bipolar back. Okay, and you have to match the trajectory with where your future stapler is going to go, which is why I'm kind of developing these straight lines. And I keep looking up and down, making sure I'm in the right plane.
Dr. Andrew.
Yeah.
What's your preferred device, the sealing device during hepatectomy?
Harmonic, but for cirrhotics, I prefer the ligature. But to cut Glissen's capsule with the ligature is difficult. So I'm using the harmonic just for Glissen's capsule. You could also use a monopolar. It would save money. It's just that since I'm not paying for the instruments, I'm treating myself to both instruments to make my life easier. That's a bad joke. But what I think you can certainly do this with just one ligature. But I think I'm just a little bit more comfortable in a new hospital doing it with the instruments that make me happy. And now the portal vein is right above me, so I'm not really going very deep on the underside. The top side I can take more, and I'll probably try to take more with, you can come in with the camera a little bit. I'm trying to, we're getting close to some interesting structures. All right, let's go that last little piece. Okay. So now I'm going to switch this. No, I'll just switch. I just put it here. Voila. And what's nice about the fibrillar is it gets stuck in the stapler, you can just leave it. Right? It'll dissolve, unlike the Surgicel, which you always worry is going to cause an abscess or what have you. So now I'm going to switch to the ligature. And we'll see if we can take a little bit of tissue here with the ligature. Let's see if it works well or if we have to go back to the harmonic. So can I use the button on this? This one? Yeah, okay. All right, so let's see here. So all those algorithms are working, telling me when to cut. Otherwise, I would have no idea. Now, if we had a CUSA, we would be a lot happier right now, or even a. So this is kind of why I was insistent on the staplers, because I can't get very good hemostasis in a cirrhotic. So I'm probably going to end up using quite a few staplers. But I hate to use this expression, but I kind of do transection until bleeding here. Ligature usually, actually, yeah. I would like to use CUSA, I just don't have it. So I see a pretty big vessel there. So I'm going to probably want to. Yes. Yeah, I think the CUSA is the safest way, but honestly, I haven't had access to a CUSA in 10 years. So I would like a CUSA if I could have it, but I don't have access to it. So that looks like a small vessel, so I'm feeling a little bit lucky. Maybe that's not smart. We'll find out in a moment. I'll probably do 2 cooks, but that looks like a small vessel. Yeah. So let's see. Okay. So now it's opening up like a book. We're starting to see what's going on. So we're going to stay high. But see what I don't like about the ligature? I have to push, and I have to create trauma. So let me just show you the harmonic. This is why I like the harmonic. is I'm not blindly pushing into the parenchyma. I'm activating it now. Oops, I like to do the slow setting. And I slowly insert it, and I slowly close it. But the ligature, you have to crush for it to work. So this is why I like I really like the harmonic. Whatever the new one is.
Do you usually like to work with the indocyanine green view during resection?
No, I don't use indocyanine. It was just I figured we had it, we might as well try. So you can get rid of it if you'd like. It's not helping us at all. Yeah. So let's get rid of it.
So you think it is not of great benefit?
It is if they got it 8 hours ago, because then only the tumor would be illuminated. Now the liver is illuminated, but not the tumor. It's like reverse indocyanine. Exactly. Usually the night before. Usually the night before is how you would do it. But again, my hospital doesn't have it. I would love to have it. But so watch that instrument. I'm going to cut into you.
I think the view now is better.
Yeah, it's a lot better. So again, we looked at the preoperative imaging, and there's not a lot of blood vessels here anteriorly. All the blood vessels are posteriorly. And again, I'm just going to continue along what's comfortable. Slowly moving. Nice hemostasis. So I think we can this. I might take with ligature. It looks like I can get exactly. I've already created a window. So I'm not going to take too much tissue. Small bite. This is like poor man's. Well, let me see. Does it fit? See how big it is? That's why it's such a violent instrument. It might be, but I don't think it's worth it to open it. But you see how it's just not a happy surgeon when I have to use this on the liver. But it definitely gets better hemostasis, but at the cost of damaging and getting extra oozing. If I can, yeah, I'd like to use the 10. But but again, you have the same problem, right? You're going to make a lot of trauma into the liver. So now we're going to go on the underside. So this is kind of what I was talking about, like dissect until. What's that noise? What was that noise? Oh, she was hitting. Okay, so we'll put this up here. That's fine. All right.
Hello.
Take a little bit more here. Put it up here. Thank you. All right, let's come up here again.
Excuse me, Dr. Andrew.
Yeah.
At which level of central venous pressure you prefer during laparoscopic hepatectomy?
So that's a great question. Your central venous line is useless during laparoscopy. So your only hope is that you have a good anesthesiologist. And if you really want to know that it's ready to do the parenchymal transection, is you look at the inferior vena cava. If the inferior vena cava is flaccid and moves with the movements of the heart and lung, then you know that you have low central venous pressure, but there's no other way to find out.
Hello?
During laparoscopy.
Yes, you think it has no importance during laparoscopic hepatectomy?
No. Let me rephrase it. It's of fundamental importance.
Yes.
But the reading that the anesthesiologist gives you is useless because it will be falsely elevated. So if I was doing a major hepatectomy, I would be looking at the inferior vena cava, right? But again, I'm not dissected out, and it's not fair to this patient to dissect out the inferior vena cava. But if I was, I would have a nice exposure. Come show me the inferior vena cava. Push in the camera. So, I can't see it easily here, so I'm not going to dissect it out.
Yeah.
But you look, and if it's flaccid, it's not distended, then you know it's time to do the parenchymal dissection. If it's full and turgid and swollen, Sometimes I wait 30, 40 minutes in the operating room. I tell my anesthesiologist to stop giving fluid. I just sit in a corner. I wait 30, I wait 40 minutes. Sometimes I've waited an hour.
Yeah.
And then once I notice that the inferior vena cava is not swollen with fluid, I know my central venous pressure is low, then I do the parenchymal transection. But for a minor hepatectomy like this,
Yeah.
I don't think it's important. I don't think it's that important because this is a minor hepatectomy.
Yeah.
You know?
Thank you.
Sure. So again, because he's cirrhotic, I'm moving very slowly. You know, I'm thinking he's going to start to have some structures here. I'm tempted to use a stapler, but I'm not, it's still a little too thick. So I'm just feeling here, here. There's a little something there, so I'm going to take that. Pull back. So it looks like it's time for a stapler. You see?
So, Dr. Andrew,
Yeah.
in atypical resections, we are, aware about the deep margin. So how do you make sure that you are not infiltrating it or away from it?
Well, as you can see, I have a centimeter here. I've angled down this way here. So we're going to have to look at it we're going to cut it in half once we resect it. If we have a positive margin, we'll take a little bit more. But as you can see, it's quite big. We did an ultrasound. It looked clear in this area. I don't really want to take more than 1 centimeter. I don't see the advantage for this patient. Purple, purple. Okay, yeah. So we'll get our angle correct first. Hold on, I got it. Okay. Let's take this out. I mean, we could leave it in, but I'd rather take it out. It's nice to have the powered version. Ooh, this is going to be hard liver, isn't it? We might need a blue load. This is such hard liver. Yeah. Ooh, that's hard liver. So I think we might have to make it a little thinner. Let's try the 10. The blue load instead. So this hasn't fired, but let's do the blue load instead. So we just put this back here. And can I have a grasper, please? Thank you. Okay. Ooh, that is some hard liver. Aspiration, please. Aspiration. Can I have a sponge, please? Sponge, please. Open it. So I like to just put these for retraction also. Sometimes you're, I'll take the fibrillar, please. Yeah, let's open this up so we can get that in there a little bit. Hold on. It's okay. Okay, it's all right. So this is thick, thick, thick. Yeah, we're going to have to thin it more anteriorly. It's very, very hard. So we'll stick that there. You can hope you can push that there. And then we will work on it up here. Okay, we can hold off on the fibrillar for now. So here. Like that. Okay, aspirate. Aspirate here. Yeah, okay, and push. Yes, that's it. Okay, let's go up here. Of course, but then you have the higher risk of liver failure. Let's look. No, I mean, this is in cirrhotic patients. Let's try. Okay, let me get another hold this, another sponge, please. She's got to open it all the way. It's not open. Yeah. Thank you. I don't like to retract the liver when it's cirrhotic just by itself. So hold that up like that. Yeah. Okay. Do we have a liver retractor? Might be better to use a liver retractor. You got it? Okay, let's look under here. Under here? Yeah, that's it. I think I'm going to put another trocar to hold this up better. Okay. Ah, this is so painful. This is, oh my God, very painful. It almost works. Do you think there's any way they can put these blades closer together so that I can use it properly, or no? You don't think so? Okay. Okay, that's... Oh my, this is... Yeah. Yeah, I'm trying to. But it's hard without...
So excuse me, why are you doing the pedicle dissection?
To try to get the vessel to segment 3.
Okay.
Might as well.
But you can get it from the round ligament, not from here. If you have the round ligament, you can get it. The first branch will be segment 3.
Oh, you mean if I yeah, no.
Not from the radical here, from the round ligament.
You're saying from here? Yeah, but then you want me to take all this extra liver, which is a shame.
If you pull on the round ligament, first branch will be segment 3.
I can't grab this. Grasp her, please. You know what? Let me get the ligature. Ligature. What's this? Get this out of here? Yeah. Okay, let's lift this up. He's got to really lift it up for me. Yeah. 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 We'll try to get it from here. The problem is laparoscopically, our trocars are a little bit awkward. You know, I was thinking of a left lateral, but now we're doing segment 3. So my
You are using the harmonic now, Dr. Andrew.
Oh, thank you. Thank you very much. So, okay, let's put a 12 right here. I think this is what we need to do. Put a 12 here. Yeah.
You are deciding to do local resection.
Yeah. Yeah, I'm coming through here.
If you come through here,
Yeah.
you don't need.
Yeah, I'm trying to. I'm going to try to put a stapler from this direction. That's why. Yeah, we'll get the blood flow in the right direction again. Okay, so here. No, you're going to hold probably. I'm thinking you're going to hold this way. Hold this. Maybe like this, and I'm going to try to cut through here. No, I'm going to hold this. You're going to hold this. Can you have a locking instrument, please? Something that locks. Yeah, see? You know what? You're just going to make bleeding, so I'm not sure if it's worth it. Let's see. Yeah, let's just put this over here. It's okay. Just gently, just get that out of our way. Let me get the harmonic. Let me get the bipolar. We'll try a blue 45. The tissue is very difficult, very hard. Let me go over here. Okay, let's see. Oh, we're a little low here. Just get rid of this. Okay, that's fine. Where the hell am I? Ah, here I am. Okay. Okay. Yeah, it's okay. Yeah, no, I'm just trying to get this exposed. Here. Hold this. Hold this. Hold this. Yeah. Bipolar. It's okay. I'll hold it. Don't worry. Come back here. Yeah. pull back a little bit? Yeah. Yeah, that's nice. Can they rotate the left side of the patient down? Yeah, much more, more. More. Okay. Okay, this is a big left live. Keep going, more. Can you do more or no? Ah. You can't do more? Look up the camera a little bit. Look up, that's it, yeah. Yeah, it's okay. Look up with the camera. Pull. Okay, so we can connect the dots here. Maybe. I think I got into something I shouldn't have gotten into. Problem is, let me get the pull back. Yeah, I would like to staple, but it's not letting me staple. Where's the suction? No, where's the sponge? Okay. Oh God, this doesn't grab. This is torture. Okay. Let me, aspirate. How do you aspirate? Here, this one? I'm going to try a stapler, but it's not letting me staple. The tissue's so hard, you know? Oh, I know. This is difficult for you guys. I'm glad I don't do cirrhotic livers. All right, let me get another sponge. Yeah, I'm gonna try. Yeah, no, I know, but hopefully I can get the stapler inside. Yeah. It's pissed off. Okay, well, it looks like I'm pretty glad I have the. Hold on. Let me do the Pringle at this point. Hold that there. Hold this. Yeah, hold that down right there. Hold that right there. Hold it. No. With your instrument. It's through your trocar. Okay, push there. Thank you. Let me get another instrument. This, I need another one. I can see why you were suggesting I do the Pringle now. Oh, the damn, see, this is why you hate the clip. Oh, it's only on one. Aren't I lucky? Okay. 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 Okay, let's see the stapler. Let's see the stapler. The blue stapler. It doesn't articulate? Oh fuck. It doesn't articulate? No, let me try the blue. Let me try the blue. No, let me try the. You want to try 45? Okay, try. Can somebody time the Pringle? Okay, good. Okay, let's see if I have the right angle with this. I don't think I do. Oh, not so bad. Okay, so let me get a grasper. Grasper. All right, you're going to have to, so pull that, get rid of, move, yeah. Okay, get ready to aspirate. Not looking so good. Not very happy, is it? Another one, please. The blue is working better. It's stronger. No, don't do that. Don't do that. Hold it closed. 45 was good. 65, it doesn't work. It doesn't work, the 45. Yeah. It's too hard otherwise. The problem is how many more do we have? All right, does the aspiration work? Suction works? He doesn't look happy. He doesn't sound happy. Sorry. Yeah, just change it. It's not worth it. You're right. Of course, but we would have had the same problem. But yeah, I agree. It's just he's an abnormal liver. It's the left side is very big and it's very low, and it's covering. Yeah. No, I think for cirrhotics, you are correct, because I have like I said, I do mostly colorectal, and we're good. Okay, so let's get set up for success. Let's move this over here. Let's go in there. Yeah, move the suction. I don't think we're happy yet, but we're going to fire anyway. I hope that sucker's not in there. Ooh, that is thick tissue. Okay, push it over. Yeah, it is slowly but surely. All right, let's get the whole surgica of this thing. Cut it here. Cut it here. I need the big piece. Cut it here. Give me this. Yeah, all of it. I'm going to put the Surgicel, then I'm going to put a, so hold the liver over. Hold the liver over for me. You get a grasper maybe, and hold the liver like that. Open, yeah, yeah, you good? Okay, good. So, let me grab this. No, you got this? Okay, hold that. Grasper. I would like the bipolar, but it's not letting me grab anything. So you guys definitely need a bipolar that grabs. Yeah. Yeah, we're less depressed than we were a few minutes ago, that's for sure. So, yeah, definitely. Nothing like a good old stapler to solve the problem. All right, let me get a sponge. So we're going to put that in there. We're going to clean up. We're going to remove some other ones and. Oop, I'm sorry. Thank you. Ooh-la. Okay. So, as you can see, you can get pretty nice hemostasis, even laparoscopically. You just have to not get too excited, take your time, hold pressure just like in open surgery, and you can really, proceed. So, you're going to keep pushing that way. We're going to I'm going to get the aspirator. I'm going to clean up a little bit. Yeah, exactly. 45 works much better. We now know that. So how do I get this aspirator to work, folks?
So for the time of Pringle, the audience are asking.
Oh yeah, what is the time of Pringle?
Now it's 7 minutes. So
okay, so we can take it. I think we can take it off. Thank you. Usually I do between 5 and 10 minutes, but you can go up to 15.
Okay.
It's only 5 minutes? Okay, so how long do you guys use?
It's 15 minutes.
Yeah, okay, so I'm going to use like you. We'll use a little bit longer. We'll clean up. Because my aspirator's not working very well. I gotta be honest. Aspiration, not really doing anything for me. I don't know if we could get it working. Okay, let's see if this works a little bit better. Oh, that's better. Oof. You poor guys. This aspirator is not fun. You don't use the striker, huh? The automatic aspirator with a little energy. I highly recommend you get that also. The striker disposable suction irrigator. You guys know that? Yeah, I highly recommend it if you're going to do liver surgery laparoscopically. I mean, you can do it this. Yeah. This is like I'm losing valuable minutes here, which you're probably used to, but I don't think it's it's not when you're starting. It's better to have good aspiration, better, and irrigation. So how do I irrigate, for instance, right now? Yeah, but how do I do that? So I have to...
Dr. Andrew,
Yeah.
are you satisfied with control of bleeding yet? So you are clearing the field?
I'm satisfied, but I'm not thrilled yet. I want to remove this, and then I need a grasper. I'm going to clean up a little bit more before I take off the Pringle.
Don't you prefer to remove the tumor before removing the Pringle?
Well, actually, I would like, it's not a bad idea, but I like to give the liver a drink, So I'd like to take it off and see if I'm still bleeding. If not, if I'm still bleeding, I'll redo the Pringle, and then I'll just do what you said. But, okay. You guys know better than I do. So let's take a look. Let's see what's going on. We'll keep going. It looks happier, right? So I like those. Yeah, if you want to, that's fine. Sure. I think we'll take another of those 45. They're working very nicely. And we'll just continue. Yeah, we'll clean the camera, and we'll continue with the resection. We'll take another blue straight that's much better for cirrhotics. Who knew? Who knew? Better for Egyptian cirrhotics. It's a whole other level. It's a whole other level of cirrhosis here in Egypt, I notice. Okay, so I'll take a blue load when you're ready.
We have Egyptian 5 minutes and Egyptian liver, Dr. Andrew.
Sorry?
We have Egyptian 5 minutes. For any waiting time, we say after 5 minutes. And in liver, we have Egyptian liver too.
5 minutes? Oh, I like it, yeah. All right, so let's see what I think we're going to try. So yeah, let's drop that, drop it down, let go of it, yeah, because actually we're going to try to go this way, because remember, you got to, it doesn't articulate, which is going to be difficult for you guys. So, show me a little bit better. Oh yeah, okay. All right, so let's try that, and I think we're going to finish the story with staplers. Oh yeah, that felt good. Okay, I think we're happier. I could probably resect this now with energy, but I don't mind using the stapler. If yeah, so aspiration. Let's just get some aspiration here. Here, we can put that.
Dr. Andrew, if we go back in time, would you perform a laparoscopic surgery for this patient?
Of course. Why not? I probably would have approached it from medially instead of laterally. I tried to get away with only using 4 trocars. You know, now that we know the staplers that work, I think we're in better situation. You know, because we had a problem figuring out which staplers work for him. Another stapler? Yeah, I'll take the stapler first. I'm going to take one more bite, and then we're going to stapler. Okay. Okay. So yeah, get rid of that. Ooh, that is hard liver, man. I wonder if I should go there. I was hoping to get a little bit more, but that's okay. That's good. Yeah, that's good. Thanks. Okay. Aspirate. Yes, I'll use some energy. Bipolar. Again, we only have to worry about one side. Can you get one more stapler? I'm going to do this last thing on the bottom. You still need blue or purple one? I think blue, yeah. Nothing, it's not really working. The purple didn't work. That's fine. All right, let's lift this up. Pull back, pull back. Suction for me, please, because I can't see. So where is the end of the tumor? Can you irrigate a little bit, maybe? Yeah? Here? Yeah? Where the hell is where's our tumor? Come to the other side. Ooh.
Yeah. So we still have a ways to go. Okay. Okay, so let's pull back. So how many minutes are we with the... How many minutes? 12? All right, so I would like to take it off if that's okay with everybody.
Yes, it's now 15 minutes.
Yeah, I would like to take it off. So let's get the sponge back in here. We can always reapply it. Yeah, this is fibrillar. So let's get a sponge. Let's see where the sponge is. Let's take this up here also. Is this a sponge? Is this fibrillar? Who knows? Who knows? Who knows? Okay. Okay, yeah, we're going to go to it right now. Push that over for me.
Okay.
Grasper, please. Just like that. Thank you. Yeah. Okay. Oh la la. Okay, thank you. All right, let's look at here. Let's look here. Okay. Aspiration, please. Oh, let me have another grasper because this is not going to do anything for me. I need a Maryland, I think. I need a Maryland to undo this. Maryland? Otherwise, I'll never get this off. Okay, let's look. Come in closer. Thank you. Do I have another Maryland? Okay, looks like it's essentially, it's very hard to grab with this. I would recommend a needle driver or a Maryland to undo this. It looks like as you can see, the Pringle is not very strong and we still have good hemostasis. This is kind of like a very lowly effective Pringle. If you want to do a stronger Pringle, use a, thank you. If you want a stronger Pringle, I would use a Morel through one of the trocar sites. Do you know that, where you have the red rubber catheter? You know, and that I think is also a good idea for these cirrhotic patients. I would probably use a more aggressive Pringle maneuver. This is really just for the instances that we had today when you don't think you're going to need it, and then you're glad you have it, so you can do it quickly. But if you do a major resection and you have to do, if you have to do more of a Pringle maneuver more often, I would use a Morel. Oh, thank you. So I'm just going to set this up again, let the liver drink a few minutes. We're holding compression. We're almost done. But you find patients with cirrhosis after laparoscopic hepatectomy, they have much less lung problems and decreased ascites. So granted, he lost a little bit of blood, but I wonder, an atypical and open surgery, what he would have lost. I don't know. No, I don't think, blood loss always looks more on laparoscopy. You know, it's always magnified. Pull back. I'm just trying to set this up in case we need to do it again. So where are we here? Here we go. So I'll just set this up, and then we'll finish the resection, and I think we'll be done. Oh, I learned my lesson. Oh, my goodness. You kidding me? Of course. I learned my lesson. Fool me once, shame on you. Fool me twice, shame on me. Right? You know that expression? Yeah, I learned my lesson. I'm not touching an Egyptian liver without the Pringle maneuver. I'm not even touching it. There we go. Okay, so we'll just set it up again. We're ready. If we need it, I'll put a clip on it. Though, you know what? I think a clip will just annoy me at this point. But because we're towards the end. So we're almost done. So pull that off. Let's just take a look, see how it looks. It's much happier. It likes It likes the medial to lateral approach a lot better than the lateral to medial approach. So I think we can progress now, probably with energy or a stapler. Let's see. Yeah, we'll try. Let's take the ligature. I'll take the bipolar and the ligature. Yeah, this is the lovely advantage of having some bipolar. The lovely advantage of having so many senior surgeons around me right now. If only we could operate like this every day, right? So the problem is the staples. It's not going to work now, so we're obliged to use the stapler. You see? So I'm glad you got to see that problem. So that's the problem. That's why I tried to use the stapler as late as possible. One more stapler, please.
Dr. Andrew.
Yes. Nice
What's
save.
your opinion about the Egyptian liver?
Sorry? Oh, my God. I don't know how you guys don't drink alcohol, because I need a drink after this case.
This is a situation we face every day.
Yeah. No, it's... I know. This is... I'm spoiled. You gave me the easy one for the foreigner, I'm sure. You
I think colorectal liver metastasis is much nicer than our liver.
Okay, so what happened here? Did that work? Let's see. Oh, it broke. Oh, maybe not. Think it broke? Let's see. Oh, no. Is this... what's going on here? You want to try it? No, it's firing. Is it? Let me see. I hope it's not misfiring. So when it's really hard, I'm going to wait. That is what I call a hard liver. That is crazy. Oh my God. This is crazy. I almost wonder. That was brutal. That was not fun at all. What did I just cut through? Is there metal in there? Yeah. Okay, so let's...
Dr. Andrew, do you have any experience in management of colorectal metastasis in cirrhotic patients?
No, I don't think, no. We don't do that. If you have cirrhosis and colorectal, no. So yes, but we see it's more peleosis. It's more due to chemotherapy. It's a different type of cirrhosis. So we call it peleosis, but we don't... To see?
Do you think, Dr. Andrew, that liver cirrhosis is a protective against colorectal liver metastasis?
Oh, that's interesting. Well, that would be an interesting paper. You guys would have the numbers to prove that. I don't know. All right, so remove everything and take another trocar. Oh God, there's a... Oh, watch out. There's staplers sticking. I didn't stick myself, but I almost did. So I have to get a little betadine. There's a stapler on the stapler sticking through that... Let me get a little betadine. I don't see blood, but it sure felt like... Yeah, that goes fine. Okay. I'll come right back in. Let me get a little more. Can I get more? Can I have a gown? No, I didn't see blood. I didn't see it, so lucky me. There's a stapler inside the staple. There's a metal staple sticking through the stapler because, yeah. I think it was stuck remember, we weren't able to remove it. I think it was a staple firing on a staple. Like one of the staples that was left inside was in the new staple line, and it jammed, and it was sticking through. But that's good for you guys to realize when next time it's staples, don't grab the tip like I just did, because yeah, 1 second. Okay, let's see if we can finish this. Okay. So let me get the ligature, please. I'm going to try again the ligature, but I'm probably going to have the same problem. You know what? The harmonic works better in this situation because it'll actually cut through. So I need this. Is the bipolar? Great. Okay. So the Pringle has been off. As you can see, the hemostasis is nicer. And now we can finish what we started over here. Okay, so let's go over here. Yeah, it's just hanging on by a thread. Yeah, see if you can get a little better suction for me. Just waiting so we... All right, let's see what this thing over here is for a second. I don't know what this is. Suck. You see that staple, for instance? That's the type of thing that was floating around. Yeah. Yeah. Watch the aspirator. No, pull back. Don't just... So can you tell him that if he just puts a sucker on a blood vessel that's bleeding and aspirates, he's going to make blood loss quicker. So he's got to suck, move away, suck, move away, but don't just stick a sucker right on a bleeding vessel, which is what I used to do when I was in training also, but not the right answer. I think we're done. Yeah, I think we're done. Okay. I think we have enough. Let's see. Let me just... So can we aspirate on this? Let's just start cleaning up a little bit. But you can see that's a big raw liver surface. Yeah, no, so I don't use irrigation much. Yeah. It makes the operative field a mess. You only do it once you really have a lot of bleeding, and you have no choice. But I try not to use irrigation until the end of the procedure. Because no matter how much you aspirate after you irrigate, there's always something annoying leaking somewhere. So as you can see, this bipolar doesn't like us anymore. It's not spray anymore? Oh, you don't have spray? You know, you guys know what the Habib is, right? I could see better. Dr. Habib was from what, Lebanon? He's Egypt, okay. So I can see better why that would be a nice device during laparoscopy, because, you need it here more, maybe. So this is a very, very anemic bipolar. I'm doing my best, but it's... No, that's not going to make a difference. That's not going to make a difference. So let's just hold compression. That'll do the trick. But as you can see, we're pretty hemostatic. Let me remove this. Let me get a grasper. We have 3 inside? Okay, great. Of course, of course. Even normal liver is the same thing. But I think in someone with HCC and colorectal, it's worth it. But again, you guys do more transplants. You have much more experience than I do. I could see why you want to do an anatomic resection better now, for sure. For sure. Because, well, you're going into, well, the hardest thing is the hard liver is really. So what was the blood loss about? Yeah. Exactly. So, you know, we had it looked more dramatic than it is, but 100 cc blood loss, doing it laparoscopically, I would definitely do this again laparoscopically. Though you should probably ask me in 30 days when we're sure the patient did well. Okay. All right. Okay. So. Okay. Take this. Yep, thank you. Excellent. You've been paying attention. Put that there. We'll take another grasper. We'll take out the tape. We don't need that anymore. You have it already? Thank you. So that's that. And now let's search a little bit more for a few more fibrillars. I was worried about post-op abscesses. We'll put a fresh layer. One more. Let's try again. Okay. Let's take this out. All right. Yeah, we're gonna buzz everything, but like I'm just getting everything clean right now. So, what's this over here? So can we irrigate? Oh, let me get this out first. So yeah, so let's irrigate over here. You can irrigate now. You can irrigate there. Yeah, be nice to the spleen. Okay. Because you know he's going to have portal hypertension, so yeah. But yeah, you poor guys in Egypt. Oof. So much liver disease. We have a lot of pancreatic disease in France. Yeah. Yeah. Yes. Yeah. Well, yeah, but not. I mean, this is, Lord. That's nice. Great. So you can irrigate now. I think you can start to irrigate everywhere. Yeah, that's nice. Okay. There you go. Yeah, irrigate all that. They can flatten out get rid of the Trendelenburg a little bit. Flatten out the patient. So aspirate here. Up top. Yeah, that's nice. So irrigate, yeah. Yep, irrigate all this. Yeah. Irrigate a little bit here, a little bit here. Let's look under the liver over here. Now he almost has a normal-sided left liver. Now this is the way it's supposed to look. Okay, so we'll take the bipolar. Okay, thank you. Yep, that's nice. You can take all that. Hold on, here I come. Yeah. Yeah, once. As always, once the tumor is resected, everything's much happier. Yeah, you can irrigate again. Ooh, that's nice. Yeah. Irrigate, yeah, let's clean this area. So we use 4 staplers or 5? 5. Okay. Yeah. Okay. Yes, it was well worth it. You want to irrigate again, or are you okay? Let me do a little bite. Let me do a little hemostasis here. So what year are you guys? Are you attendings?
No.
Residents?
Assistant lecturer.
Okay. Okay, so finished residency?
Yes, of course.
Yeah, okay. Yeah. It's like a baby professor. I mean, it's baby assistant professor. I remember. I was when I started, I was an instructor in surgery was my title. So you can see the bipolar is working very nicely now. She's doing a nice job of cleaning it off. Yeah, it works. Exactly. So this is better than nothing, but you know, this is yeah. Well, I mean, maybe, just because this isn't working very well. But I mean, you know, what's aspirate? Oh, this is just, let's get rid of the tumor now. There's the other way. No? Oh my, use a glove? Okay. No drain. No drain. No drain. But that's a good question. Maybe, well, hold on. That's a good question. Do you drain your cirrhotics? I don't. Do you put a drain? Maybe for the ascites? For the ascites? Yeah. We're gonna put in a drain because of the cirrhosis. Yeah. Usually for like a non-cirrhotic, no drain. But because of the postoperative ascites, I think it's a good idea. Yeah. Well, 48. All right, so you guys show me how you remove this. I think you guys have more experience than I do. Yeah. Oh, here, let's grab that little thing right there. No, this, this thing, yeah, perfect. Afterwards, yeah. Now it looks good. Yeah. Thank you. Always exciting. Never. Liver surgery is never easy. Every case is it's like you're reinventing the wheel. But I think we got a nice resection, so. You want to come here? You want to come here? You come here? Yeah. I'm trying to make myself. Oh yeah. No, but the instruments are very good, So. No, thank you. The honor is mine. This is great. So am I still on? Oh yes, looks. Are they looking at the other one maybe? I don't. I think they're looking at the. No, I would just. He's a man. I would just. If it's a beautiful woman, fan and steel. Usually they have an incision already. With this, I just enlarge one of the incisions. Yeah, I mean, I don't think it matters. Whatever. I would just enlarge one of the trocars. Yeah, why give him another incision? You know? Why? It's a small specimen. I think for women, then fan and steel is nice, but for men don't care. You know, they like their scars. So good, I'll let him figure out how to remove this. Yes, excellent. Good job. Yeah, I bet. Yeah, we don't. I don't know what the hell's going on. Yes. So that's interesting. So you moved back to Egypt when? Oh, wow. Good for you. And I'm curious to talk to you because. Yeah. No, but I love. I don't. Can I take off the? Can I take this off somehow? Yeah, I think. Yeah. Thank you.
الصورة فين يا جماعة؟ الصورة مش عندنا. ايوه عايزين صورة بتاعت العمليات ولا خلصنا؟ دكتور اندرو do you hear me؟ دكتور اندرو مفيش صوت.
دكتور انجو يا فندم خرج بره الاوضه يا فندم خلاص.
يعني كده خلاص وخلص؟
ان شاء الله يا فندم.
تمام.
الشركات الراعيه بس.
في اي سؤال او اي استفسار او كومنت يا جماعه؟ شكرا جزيلا يا جماعه، شرفتونا وكتر خيركم، ونوعدكم ان شاء الله مش هيبقى اخر ورك شوب، هيبقى في حاجات تانية اقوى واكبر باذن الله. شرفتونا بحضوركم في الجو البرد ده، فكتر الف خيركم. متشكرين جدا وكل سنه وانتم طيبين. الورك شوب الجاي هيبقى عن الليفر ترانسبلانتيشن. طبعا ناس انترست. طبعا ما فيش. خلاص يبقى الورك شوب الجاي هيبقى على ليفر ترانسبلانتيشن، وتشرفونا اكيد. شكرا جزيلا. متشكرين يا جماعه، متشكرين.